Good morning, everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is June 21st, 2023, and I am pleased to call today's ACIP meeting to order. I'm going to turn it over to Dr. Melinda Wharton, our Executive Secretary, to begin with our purpose and our process this morning and any announcements she has.
Thank you, Dr. Lee. Next slide, please. Good morning and welcome to the June 21st through 23rd, 2023 ACIP meeting. Copies of the slides being presented at this meeting are or will be available on the ACIP website. Additionally, we share slides through a share file link with ACIP voting liaison and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please keep your lines muted at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just no live video. And we ask ACIP voting members to turn on their video during votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first will occur today at 4:15 p.m. Eastern Daylight Time, and the second one tomorrow at 4:50 p.m. Eastern Daylight Time. To create a fair and more efficient process for requesting to make an oral comment, we ask that people interested in making an oral comment submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blinded lottery to determine who the speakers are. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2023-0035. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. And finally, we are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the committee. Detailed instructions for submission of names of potential candidates to serve as ACIP members are now available on the ACIP website. The deadline for applications for ACIP membership is August 1st, 2023, for the 4-year term beginning July 2024. Next slide, please. And with that, I will turn the meeting back over to Dr. Lee.
Thank you, Dr. Wharton. And today we will start with the ACIP member roll call. I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. I'm going to start to my right this morning. Dr. Talbot.
Good morning. This is Kip Talbot, Professor of Medicine and Health Policy at Vanderbilt University Medical Center, and I'm a practicing infectious disease physician. Oh, no conflicts.
Thank you. Dr. Chen.
Wilbur Chen, adult infectious disease physician, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Lair.
Good morning. I'm Dr. Jamie Lair. I own a private practice, family medicine in Ithaca, New York, and I have no conflicts.
Thank you. Ms. Bata.
Good morning. Lynn Bata, public health nurse and immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you, Dr. Daly.
Good morning, Matt Daly. I'm a pediatrician. I'm also a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado. I have no conflicts.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you, Dr. Brooks.
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, and Interim CEO, and I have no conflicts.
Thank you, Dr. Sanchez.
Good morning, Pablo Sanchez. I'm Professor of Pediatrics at Ohio State University, Nationwide Children's Hospital, Neonatology and Pediatric Infectious Diseases. Thank you.
Thank you, Dr. Long.
Good morning. I'm Sarah Long, Professor of Pediatrics at Drexel University College of Medicine in Philadelphia and practicing pediatric infectious disease physician. I have no conflict.
Thank you, Dr. Cotton.
Good morning, Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I am involved in a clinical trial with Takeda involving an investigational antiviral agent. This does not involve vaccines. Thank you.
Thank you. We'll go back to Dr. Sanchez. Dr. Sanchez, do you have any conflicts?
I have no conflict.
Thank you. Dr. Sineas.
Good morning. I'm Sybil Sineas. I am an Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University. I am a practicing internist and pediatrician, and I have no conflicts.
Thank you, Dr. Paling.
Good morning. I'm Kathy Paling. I am Professor of Pediatrics at Atrium Health Wake Forest Baptist, Wake Forest School of Medicine. I am a practicing pediatrician, and I have no conflicts. Thank you.
Thank you. Dr. Bell?
Good morning. I'm Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. And I'm Grace Lee. I'm Chief Quality Officer at Stanford Medicine Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. For our committee, we have quorum, and so we're able to proceed today. For our ex officio and liaison members, I'll announce the organization name, and then please indicate if you're present and your first and last name. We'll start with the Centers for Disease Control and Prevention.
President Jose Romero, Director of the NCIRD. Thank you.
Thank you, Dr. Romero. Centers for Medicare and Medicaid Services.
Good morning. Mary Beth Hance for CMS as president.
Thank you, Ms. Hance. Food and Drug Administration.
David Caslow, Office of Vaccines Research and Review.
Thank you, Dr. Caslow. Health Resources and Services Administration.
Good morning. Melinda LaSalle and Commander Dr. Reed Grimes are online, present.
Thank you. HRSA. Thank you. Indian Health Services.
Good morning, President Matthew Clark, Indian Health Service.
Thank you. National Institutes of Health.
Good morning, John Beigel from the National Institute of Allergy and Infectious Diseases.
Thank you. Office of Infectious Disease and HIV/AIDS Policy. American Academy of Family Physicians.
Pamela Rockwell, present, AAFP.
Thank you. American Academy of Pediatrics.
Sean O'Leary, present.
Thank you. American Academy of Pediatrics Red Book. We'll move on to the American Academy of Physician Associates. American College Health Association.
Sarah Lee, American College Health Association, present.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Linda
Diana
Eckert.
Joseph, present.
And Linda Eckert, present.
Thank you both. American College of Physicians.
Jason Goldman, present.
Thank you. American Geriatric Society.
Schrader Perigia.
Thank you. American Health Insurance Plans.
Good morning, Jessica Grab, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle and Courtney Londo for ERA.
Thank you. American Medical Association.
Sandra Freihofer, internal medicine physician in Atlanta, representing the American Medical Association.
Thank you. American Nurses Association. American Osteopathic Association.
Dan Grog, present.
Thank you. American Pharmacist Association.
Kelly Good, present. Thank you.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, present.
Thank you. Association for Prevention, Teaching, and Research.
Good morning, Christy Mulling-Jessel, APTR, present.
Thank you. Association of State and Territorial Health Officials.
Manisha Jutani, Connecticut Health Commissioner and ID physician representing ASTO, present.
Thank you. Biotechnology Innovation Organization.
Phyllis Arthur, present.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, present.
Thank you. I believe our Canadian National Advisory Committee on Immunization representative may be a little bit late, but we'll see if she can announce herself later. Infectious Disease Society of America.
James McCauley, present.
Thank you. International Society for Travel Medicine.
Good morning, Elizabeth Barnett, present.
Thank you. Oh, I'm going to go back to NACI, please. Dr. Deeks.
Yes, Shelley Deeks, representing Canada's National Advisory Committee on Immunization.
Thank you for joining. National Association of County and City Health Officials.
This is Matt Zahn, present.
Thank you. National Association of Pediatric Nurse Practitioners. National Foundation for Infectious Diseases.
This is William Schaffner, present.
Thank you. National Medical Association.
Dial Hewlett, present.
Thank you. Pediatric Infectious Disease Society.
Grant Paulson, present.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Monica Mercer, present.
Thank you. Society of Adolescent Health and Medicine.
Hello, good morning. It's Amy Middleman, present.
Thank you. And Society for Healthcare Epidemiology of America.
Preeti Mehrotra, present.
Thank you. Are there any additional liaison members who've joined after roll call and would like to announce themselves? Okay, I don't see any hands raised, so I'm going to thank our liaison members for being present. And I also just wanted to welcome, there's a number of new liaison member names that have joined the call. So thank you for joining. We're glad you're here, and we appreciate you representing your organizations in this committee deliberation. So we will now move on to the first session of the day, which is RSV vaccines for adults. Dr. Camille Cotton is our chair, and I will turn the session over to you, Dr. Cotton.
Good morning. So we will open the meeting with discussions of adult respiratory syncytial virus vaccines. Next slide, please. We have a very busy and active RSV adult work group members, as you can see listed on this slide, and we are really appreciative of everyone's contributions. People have worked really hard over the past many months. Next slide, please. Next slide, please. Thanks. We also have a lot of contributors from the CDC, and we are really thankful for everyone's input. We have needed a lot of additional expertise, and people have really been very rapid and thoughtful with their responses. So we are appreciative of everyone's contributions. Next slide, please. So just to recap, in February, we talked about the economic analysis of RSV vaccination in older adults, looking at the CDC model. We also looked at a comparison of economic analyses of RSV vaccination in older adults, comparing the CDC model with industry models. And then we use the evidence to recommendations framework for use of 2 RSV vaccines, GSK and Pfizer products in older adults. Next slide, please. Recent work group discussions have included a review of Season 2 safety and efficacy data from the main Phase 3 trials of RSV vaccines, as well as co-administration study results with influenza vaccination. We also looked at updates to grade and evidence to recommendations for both RSV vaccines, inclusive of this Season 2 data. We also did an update on the economic analyses of RSV vaccination in older adults, inclusive of the Season 2 data. And we did ethics considerations of different RSV vaccine policy recommendations. Next slide, please. So based on that recent work group discussion, we are aiming to evaluate possible policy recommendations for RSV vaccination of U.S. older adults. And I would ask that all the ACIP members look at this slide carefully, because the questions we are asking are, first, should RSV vaccines be recommended for U.S. adults 65 and over? And should RSV vaccines be recommended for U.S. adults aged between 60 and 64 years? The current vaccines are approved for people 60 and over, and we are going to proceed with deliberations looking at over the age of 65 and over, and between 60 and 64. So please keep this framework in mind as we undergo the next discussions. Next slide, please. Here's the agenda. We will have 2 presentations from both Pfizer and GSK on updates on their vaccines, including safety and efficacy. And then we will have 2 different presentations on the economic analyses, both independently and then comparing the economic analyses done by University of Michigan, the CDC, Pfizer, and GSK. And then we will have the update to evidence to recommendations framework for both Pfizer and GSK RSV vaccines and clinical considerations for use of these vaccines in U.S. older adults. So we have a busy morning ahead. Next slide, please. Thank you.
Thank you very much, Dr. Cotton. And with that, we'll move on to Dr. Gertman from Pfizer presenting on Season 2 safety and efficacy and co-administration with influenza vaccine.
Good morning. My name is Alejandra Gertman, and I would like to thank the ACIP for the opportunity to present today. I am pleased to provide an update on the clinical development program for the Pfizer's respiratory syncytial virus vaccine in adults 60 years of age and older. Abrysvo, our respiratory syncytial virus vaccine, received FDA approval on May 31st for the indication of active immunization for the prevention of lower respiratory tract disease caused by RSV in individuals 60 years of age and older. Today, I will present additional data from Renoir and data from our influenza co-administration study. I will start with Renoir first. As you may remember, Renoir is our Phase 3 safety and efficacy study in adults 60 years of age and older. More than 38,000 participants were enrolled and randomized 1-to-1 to receive RSV pre-F or placebo. Randomization was stratified by age group. To briefly summarize the Renoir study, participants were vaccinated upon entry into the study. Safety data were collected for all participants. Unsolicited adverse events were collected for the first month after vaccination, and serious adverse events and newly diagnosed chronic medical conditions had been collected throughout the study. In terms of RSV illness assessment, weekly active surveillance for acute respiratory symptoms occurred during the RSV Season 1 and Season 2. Reactogenicity and immunogenicity data were also collected in a subset of participants. Today, I'm presenting updated safety and efficacy data for the RSV vaccine at the end of Season 1 and for mid-Season 2. Season 1 data included data from both the northern and the southern hemispheres, and a mean RSV illness surveillance period of 7.05 months. Mid-Season 2 data includes data from northern hemisphere sites only, with a cutoff day end of January 2023. For participants who were included in the Season 2 analysis, the average time from vaccination through the mid-Season 2 efficacy surveillance cutoff is 13.9 months. Vaccine efficacy against RSV lower respiratory tract disease was demonstrated in the Northern Hemisphere across 2 seasons. For RSV lower respiratory tract disease with 3 or more symptoms, vaccine efficacy in Season 1 was 88.9%, and it was 78.6% in mid-Season 2, resulting in vaccine efficacy across the 2 seasons of about 81%. For RSV LRTD with 2 or more symptoms, vaccine efficacy in Season 1 was 65.1% and 48.9% in mid-Season 2. This slide shows the cumulative case accrual curve from day of vaccination for RSV-associated lower respiratory tract disease with 3 or more symptoms. The solid blue line is the vaccine group, and the dotted gray line represents the placebo group. Vaccine efficacy is shown after day 15 and persists through mid-Season 2. And in this slide, the cumulative case accrual curve from day of vaccination for RSV-associated LRTD is for 2 or more symptoms. The solid line is the vaccine group, and the dotted line represents the placebo group. Vaccine efficacy is shown after day 15 and persists through mid-Season 2. Regarding safety, for unsolicited adverse events from vaccination through the 1-month follow-up visit, 10 to 11% of participants in each group reported any adverse event. The frequency of related, immediate, severe, and life-threatening adverse events were similar in the vaccine and in the placebo groups. In terms of adverse events reported until the cutoff day at the end of January, percentages of newly diagnosed chronic medical conditions, serious adverse events leading to withdrawal, and adverse events leading to death have been similar among the vaccine and the placebo groups. When I presented to you data last October, I noted that there were 3 SAEs assessed by the investigator as related to the vaccine. There has been no additional related SAEs reported in the study to date. Now, I would like to present data from our co-administration study with influenza vaccine. The influenza vaccine co-administration study was a placebo-controlled, double-blind study to assess safety and immunogenicity, and it was a non-inferiority study conducted in Australia. About 1,400 participants, 65 years of age and older, were randomized 1-to-1 to receive RSV pre-F and influenza vaccine at the same visit, or receive influenza vaccine and then RSV pre-F 1 month after. The study used Fluad quadrivalent, which is an adjuvanted quadrivalent influenza vaccine. At visit 1, all participants received the influenza vaccine. In terms of demographics, slightly more than half of participants were female, and the mean age at enrollment was 71 years. Nearly 20% of participants were 75 years or older. Most participants in Australia were white. In terms of immunogenicity, non-inferiority was demonstrated with geometric mean ratios greater than 0.67 for all 4 influenza strains and for both RSV-A and RSV-B neutralizing titers. The rates of participants in the study achieving seroprotection and seroconversion were similar between the groups and were above the accepted threshold for influenza vaccines, taking into account the FDA guidance for industry for licensure of influenza vaccines, which require a lower bound of the confidence interval of 60% for seroprotection and 30% for seroconversion. And as you can see on the slide, this was attained for all except for the B Phuket, which typically presents lower responses. Moving to the safety, please note that local reactions were assessed only for the RSV pre-F and placebo administration. The frequency of local reactions was a little higher in the RSV group than in the placebo groups. Most events were mild or moderate in severity, One severe local reaction was reported, and this was the case of a severe swelling in a participant who received only RSV pre-X at visit 2. The swelling reduced overnight. The participant just took paracetamol, and no site visits were required. In terms of systemic events, fatigue, headache, and muscle pain were the most frequent reported systemic events, and percentages reporting systemic events trended higher in the co-administration group. Most events were mild to moderate in severity. There were no grade 4 fevers, which means temperatures greater than 40 degrees centigrade. Severe systemic events were reported in 0.1 to 1.7% of participants after each vaccination in both groups. The median onset of systemic events for the co-administration group was from day 2 to 4, and the median duration was 1 day. For unsolicited adverse events from vaccination through the 1 month after vaccination, the frequencies of adverse events were similar where the vaccines were co-administered or given separately. The percentage of participants reporting any AE considered by the investigator to be related was low after co-administration or sequential administration. The most commonly reported related AEs was lymphadenopathy, which was reported after co-administration and was only reported in 2 participants. 8 SAEs were reported in the co-administration group 1 month after vaccination. There were no serious adverse events in the study that were reported to be related to the vaccine. There was 1 death in a participant after receiving placebo and influenza vaccine in a subject who had cardiac failure, and it was related to his prior medical history and his background conditions. There were 3 immediate adverse events reported after co-administration and none after the RSV pre-F alone that were considered to be related to the study. In conclusion, and to summarize the clinical development updates, the RSV vaccine shows to be safe and well tolerated. The vaccine remains efficacious for the prevention of RSV, lower respiratory tract disease in the first season, and shows efficacy in the initial mid-season 2 data. When RSV pre-F is co-administered with the influenza vaccine, RSV is safe and well tolerated, and we have demonstrated non-inferior immune responses for the influenza antigens as well as the RSV groups. And in conclusion, the vaccine could be co-administered when it's given with seasonal inactivated flu vaccine. So thank you. I know this is a quick update of the program. I'm happy now to take any questions.
Thank you, Dr. Gertman. We appreciate the efficient presentation. This presentation is now open for questions. Dr. Paling?
All right, so Dr. Gertman, thank you for this presentation, and thank you for sharing the update. One of the questions I have, and I appreciate the additional data, it seems like there was an important addition of older adults in the late season 1, season 2. And so I've got 2 questions. One is a simple one. Could you remind us what the placebo is? And 2 is, I would like to see, do you have the breakdown of the numbers of persons enrolled by age group? And then do you have the plot showing the vaccine effectiveness across by age group? Thank you.
Yeah, thank you for the questions. I am pulling, as I'm listening to you, I'm pulling my backup slides. In terms of placebo, the placebo is a match. So it's a Lyo cake that looks exactly like that is pre-F, but doesn't have the, the active antigens. So that's the placebo that we use in the study. The contribution of the participants in, if you just could please give me a second. And maybe my colleagues on the phone can pull the slides with the demographics for the Renoir study.
We're seeing it.
Thank you. I'm in a different screen. So when I presented data to you in October, you might remember we have about 34,000 subjects, and then we had ongoing enrollment in the Southern Hemisphere. So this is now the complete number that you could see, and the contribution to the different age groups remains approximately the same, which is about 38% for those who are 70 years of age and older. So we enroll additional subjects, but the proportion of those who are older than 70 or 80 remain about the same than the initial presentation I did to you. And did I answer all the questions?
Do you have the vaccine effectiveness demonstration by age group?
Yes, I do. And so if we can bring the slide, please, with the data. So in this, just to orient you to the slide, on the left part of the slide, you have the initial vaccine efficacy. But, when I presented to you was the interim analysis, and then we completed, right, the year one. So that's what you see on the left side of the slide, and on the right is the mid-season 2 with the caveat that I mentioned that is only for the Northern Hemisphere piece. And so you can see vaccine efficacy goes from 88.9 to 78.6. And then on the first part of the slide, on the upper rows, you see the different age groups, and you see the vaccine efficacy remains pretty high, with the caveat that the number of participants for those who are 70 and older in terms of number of cases is a little bit lower, but clearly trends on the right direction to show the vaccine efficacy remains high regardless of the age group.
Dr. Lear?
Thank you for the update, and thank you for manufacturing such a very effective vaccine. I have several questions. The first one is, could you please review the 3 related side effects? You presented them in the past, but just to review them today, what the committee decided was a related side effect.
So thank you for the question. We have 3 cases. One was the hypersensitivity, delay allergic reaction, and then there were 2 cases, one of Guillain-Barré in a male in the United States, and a case of a variant of Miller tissue syndrome in a female in Japan. Those are the cases that were reported, and as I mentioned, there have not been any additional cases of any demyelinating, condition other than the 2 that I presented to you before.
Thank you. Could you go to slide 8, please? I was trying to figure out the numbers of incidents. So if you look out to day 353, you only had 24 cases in the placebo group of lower respiratory tract disease with 3 symptoms. In a subsequent presentation, we're going to learn that there's an estimate of about 25,000 outpatient cases that need to be medically attended per million. And when I did the math, that would be about 25 per 1,000, and you had about 18,000 people. So it just seems like there's this dramatically fewer number, maybe on the order of magnitude of 10 to 20 fewer cases of RSV during your study. I was just wondering if you could comment on that.
Yeah. So thank you for the question. We, there are 2 ways of look at this. The first one is the cases that I'm presenting here are the ones that met the definition of, according to our protocol, which I presented to you in October. So they had to have 2 or 3 plus symptoms, and that's the definition per protocol. And then we also have vaccine efficacy done by those who seek any type of medical care because of the, personal need to go to a healthcare practitioner because they didn't feel well. So we have vaccine efficacy, and I did not present that to you today, but we have vaccine efficacy also to be presented to in a way of who sought medical care. With respect to your question in terms of what happened during the time that we conducted the study, the number of cases of RSV overall was lower since the study was conducted, during the COVID pandemic. And so we know that we didn't see enough cases overall, probably due to a lot of the factors that we're very familiar with, including all the non-pharmacological interventions and the fact that the study was conducted in an older population that probably was even more careful in terms of being exposed to other viruses. I think that your point is well taken, and hopefully, when the vaccine is recommended and introduced, we will be able to see a bigger impact in terms of RSV, the impact that the vaccine may have overall in RSV from mild to more severe disease.
Thank you.
Thank you, Dr. Long. And Dr. Gertman, could you please just get a little closer to the mic for us? Thank you.
Have you begun or do you plan to study second doses?
I'm sorry, my volume is not great either. So could you please repeat the question if we are studying? I didn't get.
I'm sorry. Have you begun or do you plan to study second doses?
Yeah, thank you very much. So yes, we are in the process of vaccinating 2 additional cohorts that received the initial vaccination that will represent revaccination after year 1. And then that we're doing that in the Southern Hemisphere and revaccination after 2 years. So that data will be forthcoming. And in addition, we are conducting a study in immunocompromised participants where we are looking if those who have immunocompromised conditions will require a single dose or maybe 2 doses given 1 month apart.
And are you studying immunogenicity and or effectiveness or efficacy of second doses? And when do you expect these data to be available?
Thank you. We're studying immunogenicity in those participants after 1 year and 2 years after vaccination, and that data hopefully should be ready by first quarter of 2024.
Thank you. Dr. Paling?
Can you help me understand, when was season 2?
When what?
When was season 2?
When was it? Sorry, maybe you can.
What were the dates of season 2, please?
Yeah. So the season 2 data that I presented today goes from, as I said, goes in the Northern Hemisphere, and it started in July of 2022 and went all the way to the end of January of 2023. And so represents Northern Hemisphere and what we call mid-season 2 because the season in the Southern Hemisphere started much later. So we are now doing surveillance in the Southern Hemisphere where we have thousands and thousands of participants, and we expect that completion of full season 2 data, including the Southern Hemisphere, by late 2023 or beginning of 2024.
Okay, thank you. I see 3 hands raised, and then we're going to move on. So, Dr. Daly?
Yeah, thanks so much. I was having a little trouble hearing in the room. Can you please again just describe the 3 serious adverse events from season 1? I caught part of it, but not all of it. Thank you.
Yeah, apologies. I hope that my volume now is a little bit better. So there were 3 related adverse events that were deemed to be related by the investigator, and we obviously agree with those in terms of the assessment that the investigators did. There was an allergic reaction in a participant in Argentina that was diagnosed as delayed allergic reaction and resolved. And then there were 2 additional cases of related SAEs. One was a Guillain-Barré syndrome in a participant in the United States, and additional one was a case of Miller-Fisher syndrome in a participant who is a female from Japan.
Thank you. Ms. Bata, your hand's down. Dr. Cotton.
So in looking at the co-administration studies, it does look as though there is a trend towards decreased neutralizing titers and decreased seroprotection and seroconversion kind of across the board. It might not be statistically significant, but I guess I remain clinically concerned, especially where influenza vaccine doesn't engender as much protection as we might like. So I know that your conclusion on your last slide, that there's a non-inferior immune response when co-administration with influenza vaccine happens, but I guess I'd just like to signal that I clinically remain concerned about this. I guess I'm wondering if in any of the immune-compromised trials, if this will be evaluated, because that would be especially important for the immunocompromised population.
So thank you for the question, and you are correct. There was a trend to a little bit of lower responses when the vaccines were co-administered from the perspective of the non-inferiority and the meeting of the primary endpoint of the study. We were able to demonstrate that there was non-inferiority using the 1.5, fold difference that I described to you. In terms of co-administration of flu vaccine in immunocompromised subjects is something that at the present time we are not evaluating.
I'm going to move on. Actually, we have two more hands raised, and I want to make sure that are these, but we do need to move on. Are these critical questions, or can we come back to them?
Very short question. Was it standard influenza that was co-administered, or was it some, pardon?
Fluad.
Fluad, thank you.
Okay. Dr. Sanchez, quick question.
Do you know which RSV isolates were circulating during this time? And second of all, I may miss this because of the, but can you just comment on the symptoms that were being seen, severity, mechanical ventilation, hospitalization?
Thank you. So the last few seasons have been predominantly B seasons. So we have seen about 75% of the circulating strains have been group B, and that was consistent for both the first and the second year of the study. And in terms of severe disease or hospitalization, we had only 2 cases, and those 2 cases actually were in the placebo group, and those 2 resulted in hospitalization. And neither of those cases require mechanical ventilation, but one of them requires supplemental oxygen as a way of treatment.
Okay, thank you. Dr. Gartman, we're going to need to move on, but before we go, I'm wondering if you could just please comment on the post-marketing requirement and the post-marketing commitments that you have regarding safety surveillance.
Thank you. Yes, we have, now the vaccine has been approved, and our pharmacovigilance plans have been finalized, and we are doing different studies, one to look at chronic demyelinating conditions, in addition to our active, surveillance and expedited reporting. We are also doing expedited reporting for subjects who are reporting atrial fibrillation after administration of the vaccine. And then finally, we also are looking at hypersensitivity and allergic reactions. And I don't know if you can see the slide, but also the 3 slides, the 3 studies that I just mentioned that have been agreed with the FDA and will be starting as soon as the vaccine is being recommended and given.
Okay, thank you. And it'll be really helpful, I think, for the work group and for the committee to be able to continue to review those data over time. With that, we're going to move on to our next presenter. Thank you, Dr. Gartman. Dr. Friedland from GSK, who will be presenting on Season 2 safety and efficacy and co-administration with flu vaccine.
Good morning, Dr. Lee. Good morning, ACIP members. I'm Leonard Friedland from GSK. Today, I'll present efficacy and safety results over 2 full RSV seasons after vaccination from the pivotal phase 3 study. These results recently became available and show that 1 dose of Arexvy provides durable efficacy against RSV-associated LRTD for at least 2 full seasons, including against severe disease and in adults with underlying comorbidities and across advancing ages. And that a second dose, 12 months after the first dose, does not appear to confer additional efficacy in the overall population. I will also present results demonstrating that Arexvy can be administered with all types of commonly used influenza vaccines. Let's start with the pivotal phase 3 study 006. At the time of the primary efficacy analysis, participants had been followed for up to 10 months with a median of 6.7 months, as noted on the slide as end of S1 analysis. Vaccine efficacy analyses were also conducted at a median of 14 months after dose 1 to investigate vaccine efficacy at least a full calendar year after single-dose vaccination. This was well into the 22-23 RSV season and approximately represents mid-season 2 analysis. In the summer of 2022, prior to the onset of a second RSV season, participants who received 1 dose of Arexvy were re-randomized 1-to-1 to receive either a second dose of Arexvy or placebo. Participants enrolled in season 2 were followed through March 31, 2023, representing 2 full RSV seasons after dose 1 vaccination for participants enrolled in the Northern Hemisphere. Surveillance is performed throughout the study independent of RSV seasonality. There are no standard case definitions for RSV disease severity, and these definitions differ between vaccine manufacturers. Our case definitions capture gradations in disease severity and have all been agreed to with regulatory agencies. Of note, our definition for severe LRTD includes objective lower respiratory signs. Turning to the results. The far right column in gray shows our protocol analysis plan efficacy results using age, region, and season as covariates when looking at cumulative season 1 and season 2 data. The column to the left of that in bold is the data without season as the covariant, which is in line with how the CDC will be presenting the data. The efficacy of a single dose of Arexvy against RSV-confirmed LRTD, shown in orange, was 82.6% for 1 dose in the first season. At median 14 months after vaccination, the efficacy of a single dose shown in brown was 80.9%, and shown in blue was 56.1% when looking at season 2 only. At the end of 2 full seasons after vaccination, a median of 18 months after vaccination follow-up, shown in green, the efficacy of a single dose was 74.5%, meeting the pre-specified confirmatory endpoint, demonstrating that Arexvy provides durable vaccine efficacy against LRTD over 2 full RSV seasons. On the bottom, for the group that received the second dose, the efficacy was 55.9% of the second season and 74.5% over the 2 full RSV seasons. Revaccination after 12 months does not appear to confer additional efficacy in the overall population. Now, let's look at severe LRTD, as these are important in the context of the substantial burden of disease and significant medical need in older adults. As a reminder, this definition differs across industry and are not directly comparable. Overall, Arexvy produces a durable efficacy against severe LRTD. With the single dose, the efficacy was 94.1% in season 1, 86.8% at mid-season 2, and 82.7% over 2 full RSV seasons. Turning now to subgroups. Risk factors for severe RSV include underlying comorbidities and advancing age. In the clinical trial, 39% of participants had 1 or more underlying comorbidities of interest, and 38% of participants were ranked as enrollment. In these populations, Arexvy produces very high efficacy in season 1 and durable efficacy over 2 full seasons in participants with 1 or more pre-existing comorbidities of interest and also in those pre-frail. The efficacy of a single dose over 1 season was high across advancing age groups, as shown on the top of the graph. And on the bottom, vaccine efficacy is durable over 2 full seasons across advancing ages. Efficacy was maintained in each of the RSV A and B subtypes, with 84.6 and 80.9% respectively for 1 dose in the first season, and at the end of 2 full seasons after vaccination, the efficacy against subtypes was durable. Turning now to safety. For this, we evaluated the second dose compared to the first. The data in the blue boxes is from season 2. Reactogenicity in participants who received the second dose of Arexvy is comparable to 1 dose from season 1. Here's the same layout for unsolicited events from season 2. Unsolicited AEs in participants who received the second dose of Arexvy is comparable to 1 dose from season 1. The rates of SAEs, fatal SAEs, and PIMDs are low and balanced across groups. Importantly, there were no reports of GBS, ADEM, or other neuroinflammatory demyelinating disorders. At the October 2022 meeting, we shared results from the co-administration study with standard quadrivalent influenza vaccine, showing no evidence of immune interference to any of the antigens contained in both concomitantly administered vaccines. I will now present results from co-administration trials with high-dose and adjuvanted influenza vaccines. In the trial design, 1 arm is the co-administration group, and the control group is sequential vaccination, flu vaccine at visit 1, followed by Arexvy at day 31. Here are the immunogenicity results of Arexvy with a high-dose influenza vaccine. The criteria for non-inferiority of the immune response of the control group over the co-administration group were met, as the 2-sided 95% confidence interval for the group GNT ratio were below 1.5 for flu hemagglutinin inhibition and RSV neutralizing antibodies. In the trial of Arexvy vaccine with an adjuvanted influenza vaccine, using the same success criteria, non-inferiority was met for 3 of the 4 flu hemagglutinin inhibition antibodies and for both RSV neutralizing antibodies. For flu A Darwin H3N2, the upper limit of the GMT ratio was 1.52, which slightly exceeded the pre-specified limit of 1.5. Our assessment is that Arexvy, an adjuvanted flu vaccine, was co-administered without evidence of clinically meaningful immune interference. This slide shows the rates of local reactogenicity events from the study with high-dose influenza vaccine. The local reactogenicity events for the flu vaccine are shown on the left and Arexvy on the right. On the left, we see similar rates of local events for the flu vaccine when administered at the same time as Arexvy in light orange or on its own in blue. On the right, we see comparable data for local events when Arexvy is administered at the same time as flu in light orange or on its own in dark orange. Moving now to the local reactogenicity results for the adjuvanted influenza vaccine. On the left, the rates of local events are similar for the flu vaccine when administered at the same time as Arexvy or on its own. And on the right, results for local events are also similar when Arexvy is administered at the same time as flu or on its own. Here, we see the events reflecting systemic reactogenicity with high-dose flu vaccine. There's a trend to increase mild-moderate systemic events in the co-administered group with no increase in grade 3 systemic events. And here are the events reflecting systemic reactogenicity with an adjuvanted flu dose vaccine. The trend to increase mild to moderate systemic events in the co-administered group is seen with each of our 3 flu co-administration studies, which is expected with co-administration, but importantly, there's no increase in severity. Not shown in both co-administration studies, the rates of SAEs, fatal SAEs, and potential immune-mediated disorders reported up to the data lock point were low overall and balanced between the co-administration and sequential administration groups. In summary, one dose of Arexvy provides durable efficacy against RSV-associated LRTD for 2 full seasons, including and importantly against severe disease in adults with underlying comorbidities and across advancing ages. Revaccination after 12 months does not appear to confer additional efficacy benefit in the overall population. Future data will inform optimal timing of revaccination. Arexvy can be administered with all types of commonly used influenza vaccines. Reactogenicity and safety profiles of the second dose are in line with the first dose, important for future revaccination consideration. Overall, the total safety database now includes more than 19,000 vaccine recipients with more than 25,000 doses administered. Nearly 6,000 have received 2 doses. It's reassuring that across all studies, there are no new cases of GBS, ADEM, or other neuroinflammatory demyelinating disorders with additional exposure. Thank you.
Thank you, Dr. Friedland, and this presentation is now open for questions. Dr. Paling.
Dr. Friedland, thank you for this great presentation and for the update through the last RSV season. Would you please remind us of what the placebo was in this study?
Absolutely, Dr. Paling. The placebo was the saline placebo.
Okay, thank you. And thank you for including adults over the age of 60 in the 70s as well. Can you comment on the side effects for that age group?
Yes, I can, and thank you for that question. The local reactogenicity and systemic reactogenicity in older individuals in our study compared to the younger adults in our study were comparable across the age groups.
Dr. Cotton.
Thank you. I am concerned about the lack of additional protection with the booster dose in the second year. And I wonder what that means overall for RSV vaccines and whether a one-time dose of vaccine, which it looks to be protective in the first year, but with diminished vaccine efficacy in the second year, what it will mean longer term. I do see that you are saying that you will be looking at further booster doses and what that might look like. I'm wondering if you could comment further on plans to evaluate booster dosing, and also, do you have data on neutralizing antibody after the second dose of vaccine? Thank you.
Yes, I do. There were a number of questions there, and let me just see if I can cover them. The first, if I recall, is do we have plans around modifications to our clinical studies? It's important to point out that Study 06, which I presented today, has provided important information. We are currently reviewing our clinical development plan, and we're going to look to generate additional data that will help inform the optimal timing of revaccination. Now, you had asked also about immunogenicity studies. And so I will point out, of course, that our study that I presented today shows that Arexvy is durable with protection over 2 full RSV seasons, including against severe disease and also in those vulnerable populations, such as older adults and those with underlying comorbidities. And as mentioned, Study 06 does provide important information where a second dose after 12 months does not appear necessary in the overall population. So coming to your question about immune response, first, it's important to recognize that there are no established immune correlates of protection. In our clinical development plan for Arexvy, we have an ongoing phase 3 immunogenicity trial, and if interested, I can share the data in more details with you in just a moment. But in this ongoing study, we find that the immune response induced by vaccination peaks 1 month after vaccination and persists for 18 months at levels above baseline. When the second dose is given 12 months after the first dose, there are increases in neutralization titers, but they do not restore to the level observed after the first dose. I want to point out that this type of immune response that I'm describing is also described for other RSV pre-F protein vaccines, so it's not unique to Arexvy. And again, as mentioned, further data will be generated to help us explore longer-term protection and inform the optimal timing of revaccination.
Thank you, Dr. Brooks.
Yes, thank you for your presentation. And I share the same concerns as Dr. Cotton and would like to see the neutralizing antibody data over time. My question is, do you have the race and ethnicity breakdown in terms of who was in the study and by vaccine efficacy?
Yes, I do, and there were two questions there. So the first is about the demographics in the study, and the second is about the immunogenicity data. So let me bring up the slide on the demographics. One moment, please. Actually, I would just repeat it to you. I have it in front of me. Within the study, looking at race, about 80% of those enrolled were of white race, 8.5% were Black or African American. This is across the 17 countries in which the study was enrolled. Asian race was about 7.5%. And if we look to the United States enrollment, we saw that Black or African American enrollment was at 14.8%, Hispanic and Latino 9.2%, and white 82.4%. Did that address your first question, Dr. Brooks?
Yes.
Okay. And so let me bring up to you the information you asked about immunogenicity. So I'm bringing up on a slide, I hope you can see this. It's a study we refer to as Study 004. So this is an ongoing phase 3 immunogenicity trial in which about 1,600 adults over the age of 60 are enrolled 3-to-1-to-1. The group for 3 in the randomization receives Arexvy a first dose, and then they receive a second dose 12 months later. There is an arm that receives a first dose and will receive a second dose 24 months after the first dose. And then there's an arm that just receives 1 dose and is followed. This is an immunogenicity study. As to the results, let me bring that slide up for you here. So let's focus in on the group that received 2 doses in orange. On the left are serum neutralization titers for RSV-A and RSV-B, and on the right is the cellular immune response. So looking at the group that received annual vaccination, so this is, they get their first dose, you see that the neutralization titers for A and B and for cellular immunity go up substantially after the first dose. Then they begin to decline. They remain about 3-fold higher at 12 months over pre-vaccination levels. And then when that second dose is given 12 months after the first dose, we see a rise in neutralizing antibody titers anywhere from 4 to 6-fold for A and B. And we see that that is not above the first dose levels. And then they remain about 2 to 3-fold higher 6 months later after that second dose compared to baseline. Looking to the far right at cellular immunity, we see that a second dose given 12 months after the first dose has a high cellular immune response that exceeds that seen with the first dose and then declines over the following 6 months. Now, in view of these results, we see that revaccination at 12 months in the clinical study doesn't appear to be clinically beneficial, and further data will continue to explore the longer-term protection and inform the optimal timing of vaccination.
Thank you. Dr. Lung?
With those data, Dr. Friedland, that you just showed us, why do you suppose that you saw almost zero change in efficacy? And you studied those second doses very soon after the second dose, where there would have been a substantial increase in antibodies. Does it make you think that the antibody responses that you measured and the cellular response have to be significantly greater than the boost offered?
Well, thank you very much, Dr. Those questions. These data just became available. We don't yet know all of the answers to those questions. What we do know is that the vaccine, when given as a single dose, is durable over 2 full RSV seasons, providing high protection, including in those who are most vulnerable to severe RSV disease. We do see a rise in neutralizing antibody titers with the second dose, but it does not exceed that of the first dose. We do see a rise in cellular immunity that does exceed the first dose. It does decline. We need to evaluate the data further to continue our studies that will help inform the optimal timing of revaccination.
Thank you. And a second, two other questions, Dr. Lee, okay? Were there no subjects 80 years of age and older?
Thank you for that question. In our clinical trial, about 8% of those enrolled were 80 years of age and older. We have few cases of disease in people 80 years of age and older, and we're unable to calculate a meaningful vaccine efficacy.
And the final question, I don't know when and where you conducted this second season, but in both seasons, 1 and 2, what was the predominant RSV type?
Yes, thank you. So the 006 conducted in 17 countries around the world. 90% of subjects enrolled in the Northern Hemisphere, about 10% from the Southern Hemisphere. When we looked about what was circulating through literature, we saw there was both types A and B have been circulating in different parts of the world, have different levels of circulation. In the clinical trial itself, among the cases of RSV that occurred, about 2/3 were RSV season 1 and 2.
Thank you.
Thank you. Dr. Daly?
Yeah, thanks so much. Could you please describe post-marketing safety surveillance plans, including your goal for sample size? Thank you.
Yes, I can. So we have post-marketing studies planned. There's a post-marketing requirement to study GBS and ATEM, and we have a post-marketing commitment to study atrial fibrillation. The sample size in the study, for example, to further gather data on ATEM will enroll approximately 1.5 million vaccinated subjects.
Thank you. Dr. Talbot?
Yes, could you please return to slide 16? I just want to confirm that this is the control over co-administration. So when we typically look at this graph, we look at co-administration over the control. So this is the reverse. Is that not correct?
That's correct. So the 1.5 would be 0.67.
Thank you for that clarification. I don't think I understood that previously. Ms. McNally.
Dr. Friedland, I'm the consumer representative, and I'm just curious if you can expand on the reason for the AFib post-surveillance study. Thank you.
Yes, I can. And I'm actually going to ask my colleague, Dr. Peppy Webster, who leads our safety team, to respond to that question.
Yes, thank you for that. So we had in the first season in the 006 pivotal study, we did see an imbalance, a numerical imbalance in events of atrial fibrillation with more cases in the Arexvy arm versus placebo in the first 30 days following vaccination. Based on that, we have a post-marketing commitment that we will study atrial fibrillation in the post-marketing setting. We've also implemented more active surveillance in our clinical trials. Interestingly, in season 2, after the second dose, we did not see that same imbalance. So we're going to continue to gather data and study this more.
Thank you. Dr. Cotton?
Could you discuss the studies that will be done in immunocompromised patients and whether or not multiple doses will be given over several years? Thank you.
Yes, thank you for that question. Our clinical development plan for studying Arexvy in immunocompromised patients is under development. And as we finalize that plan, we'll certainly be discussing it with the work group.
Dr. Paley?
Could you share with us how many people were hospitalized with RSV in the two groups? Thank you.
Yes, thank you very much. Yes, I can. Actually, yes, I can. Yes, so there was one patient who There were 6 total patients who were hospitalized. In the first season, there were 3, and in the second season, 3 additional. The breakdown of those cases is 1 in Arexvy and 5 in placebo.
And were any admitted to the ICU?
I don't have the answer to that question, and I'll come back to you on that answer. Again, 5 of the 6 were in placebo.
Thank you. And last question to Dr. Lehr.
Just want to go back to the atrial fibrillation. My understanding from the data is that the majority of people who had the atrial fibrillation already had atrial fibrillation, that there are actually only a few new onset cases of atrial fibrillation. And my reading was that there were 2 new onset in the vaccine group and only 1 in the placebo group. Is that accurate?
I do not have the season 1 data in front of me, but I can confirm that and get back to you.
Thank you. And, I'll ask our colleagues from both Pfizer and GSK to stay on the line because I anticipate additional questions will come up in the discussion, particularly near the end of the session. So if there's any remaining issues that haven't been able to be answered, please feel free to raise it again. Then I'm speaking to my members. Okay, we'll move on to the next presentation, updated cost effectiveness of the Pfizer and GSK vaccines, which will be presented by Dr. David Hutton from University of Michigan.
Great, thank you very much. Okay, so good morning, everyone. I'm happy to share the results of our economic analysis of RSV vaccination in older adults. This is an updated analysis from our analysis in February. For the remainder of the talk, I'm going to refer to the vaccines as RSV pre-F. I'd like to, on our next slide, I'd like to acknowledge our research team, which includes collaborators from the University of Michigan, the Centers for Disease Control Prevention, many of whom have extensive expertise in RSV. We've been working on this project for the last several years. On the next slide, I just want to mention we have conflicts to report. And then on the next slide, our overall goal is to evaluate the cost effectiveness for RSV vaccination in the U.S. population age 60 and older. We evaluated vaccination policy for several age groups, and we'll focus on the population age 65 and older. We compare the incremental cost effectiveness ratio of vaccination to no vaccination and explore scenario analyses to examine key areas of uncertainty related to these questions. We'll take a societal perspective, and in this presentation, we have several major updates from what I showed in February. The first is that we have updated our base case incidence of RSV to be elevated from what we had shown in February. Next, we're incorporating vaccination efficacy in season 2 for that single vaccine dose. And then thirdly, we're also aligning our vaccine price with that assumed by the manufacturers. On our next slide here, we're going to examine 2 vaccination interventions for the Pfizer and the GSK vaccines. Each one is compared individually to no vaccination. We're not directly comparing the 2 to each other. The base case assumes we're looking at RSV vaccination for those age 65 and older. However, we will look at other potential age groups and sensitivity analysis. We're looking at a vaccination intervention for a single dose of vaccine provided at a single time period. But we're also examining the effect of RSV over a time frame of 2 years. And then finally, we're using a lifetime analytic horizon to look at outcomes that might last beyond that time frame, like years of life lost due to deaths. We're discounting long-term outcomes by 3% per year. On our next slide here, in order to conduct this analysis, we're using a decision tree model. Our decision tree incorporates several parts to it. The top part of the diagram shows what happens with no vaccination. With no vaccination, individuals can become infected. Infection can lead to hospitalization, emergency department visits, outpatient visits, or none of the above. Individuals who are hospitalized can potentially die. The bottom of the tree, you see the outcomes related to vaccination. Vaccination may involve several adverse events, and then following vaccination, individuals might experience those same RSV outcomes you see on the top of the tree. However, of course, the likelihood of those RSV outcomes is lower with vaccination. The model incorporates information in monthly time periods to track incidence of RSV along the timing of the vaccination, and with that, we track waning protection over that time period. Because this is a decision tree model, we do not take into account any reductions in RSV transmission and also don't take into account infections that are not medically attended. On the next slide, I'll show you some key epidemiological parameters, and the key one here is really the incidence of RSV. We believe reported incidence might be underreported because of underdetection of RSV infection through the use of upper respiratory PCR tests alone. In our base case analysis, we use a multiplier of 1.5 to the crude incidence numbers of the estimated to estimate the true cases of RSV. This incidence estimate is higher than our previous analysis in February. In the sensitivity analysis, we examined both lower and higher RSV incidence. On the next slide here, it shows our estimates of RSV hospitalization incidence. These estimates come from the CDC RSVNet from the season starting in 2016 and ending in 2020. As mentioned earlier, there's considerable uncertainty surrounding these rates, and you can see that in the range column in this table. The next slide shows our estimates of RSV ED and outpatient incidence. These estimates are also higher than we had shown in February and are based on that higher multiplier to account for under-detection. On the next slide, we show seasonality. Just a reminder, we do take seasonality into account. This graph shows the fraction of annual infections occurring in each month throughout the year. Seasonality data comes from the National Respiratory and Enteric Virus Surveillance System, or NERVS. We also estimate vaccine uptake follows a seasonal pattern similar to seasonal influenza vaccination uptake. On our next slide, today's analysis incorporates efficacy of the RSV vaccines over 2 RSV seasons. This slide here shows estimates of RSV vaccine efficacy taken from the Pfizer phase 3 trial. We've chosen to split up efficacy into 2 components over 2 time periods. One component is efficacy against emergency department and hospitalizations in the upper darker line on this graph. The other component is efficacy against outpatient visits in a lower lighter colored line. We use the efficacy from the trial against medically attended lower respiratory tract infections to be the efficacy against emergency department and hospitalizations, and the efficacy against medically attended acute respiratory illness as the efficacy against outpatient visits. I want to highlight that vaccine efficacy against medically attended lower respiratory tract infections or disease is that proxy for vaccine efficacy against hospitalization and emergency department visits. We use this because each trial recorded only a very small number of RSV hospitalizations, as you just talked about in the last talk here. And so the vaccine efficacy for hospitalizations couldn't be directly calculated. So we're using this proxy here, again, of against lower respiratory tract infections and disease. We look at efficacy in the first season and then the second seasons from the trial. We assume the duration of the first season applies until month 7, which is the median reported time for the first season, and then we assume it drops to the level reported in the second season until month 14, which is the median time reported in the second season. After that point, we assume efficacy linearly declines to 0 efficacy at 24 months. The next slide shows the same thing, but for the RSV vaccine efficacy taken from the GSK phase 3 trial. Efficacy here is also higher for the more severe outcomes, and efficacy drops in the second season. Efficacy for the first season applies until month 7, which was the median reported time for the first season. And then we assume it drops to the level reported in the second season until month 18, which is the median time reported for the GSK trial in the second season. After that point, we also assume efficacy linearly declines to 0 at 24 months. So those are our base case assumptions. In the next slide, we see that we do explore some alternative assumptions about the long-term duration of efficacy, since we don't really know much beyond that second season. So we have 2 scenarios, a shorter and longer duration scenario. In the shorter duration scenario, we assume efficacy immediately drops to 0 after that median time point evaluated in the trials. In the longer duration scenario, we assume efficacy declines to 0 at the end of 36 months. The next slide shows medical costs associated with RSV infections. This table shows estimates of costs for hospitalization at the top, then emergency department visits, then outpatient visits for RSV. These estimates are taken from a variety of sources that have estimated cost of RSV. Most of these are the same as what I showed in February, but I do want to highlight one update in today's presentation. that we now incorporate costs of follow-on care that might occur subsequent to a hospitalization, like rehabilitation care or hospital. We've incorporated that into our hospitalization costs at the top of this table, so they're slightly higher than what we showed in February. On our next slide, I just want to highlight that we're not showing all of our inputs, but I want to mention we included additional inputs related to RSV health impact and costs, as well as costs associated with vaccination. We also include vaccine adverse events and quality of life, medical and productivity costs associated with those adverse events. These assumptions remain unchanged from February. The next slide shows, I want to highlight we conducted several analyses of uncertainty. We conducted one-way and two-way sensitivity analyses. Our base case looks at age 65 and above, but we also examined a policy of vaccinating those under age 65, ages 60 through the end of the 64th year. In some scenario analyses, we also examined shorter and longer duration of vaccine efficacy. Okay, on the next slide here, I just want to highlight our results. Start with a base case of the population age 65. And in today's analysis, I also want to highlight we use a $200 vaccine cost for the Pfizer vaccine and a $270 cost for the GSK vaccine. These are updates from last time. This is in line with the latest costs that the manufacturers have been using in their analyses. And in addition, again, I want to highlight we're using a 2-year time frame. Okay, so now on the next slide here, we're showing the number needed to vaccinate to avert one of a variety of different events for the Pfizer vaccine. Each different colored bar represents a different age-based vaccination strategy. For example, we would need to vaccinate 40 people aged 65 and older to avert one outpatient visit. But to avert one death, we would need to vaccinate 7,842 people aged 65 and older. You see the numbers needed to vaccinate are higher for the younger age group, age 60 to under 65, because the incidence and severity of disease are not as high in that younger population. On our next slide, we have the net cost per outcome averted for the Pfizer vaccine. This is the net cost, so it already includes cost savings from the averted events. If we look at the last column, for example, we can see that there's a $1.1 million cost per death averted if we're vaccinating the population age 65 and older, or a $4.8 million cost per death averted if we're vaccinating the population age 60 through under 65. On the next slide, we show some numbers needed to vaccinate, but for the GSK vaccine, these numbers are very similar to the Pfizer vaccine. On the next slide, we also are showing the net cost per outcome averted, but for the GSK vaccine, these numbers are higher than that for the Pfizer, but mainly because the GSK vaccine is expected to be 35% more expensive than the Pfizer's vaccine. Okay, on the next slide, this table is showing the cost effectiveness results for the Pfizer vaccine. We anticipate the Pfizer vaccine would have an incremental cost effectiveness ratio of $94,673 per quality adjusted life year gain for a population aged 65 and older, but have an incremental cost effectiveness ratio of about $218,000 cost per quality adjusted life year gained if given to a younger population in that age group 60 to under 65. The next table on the next slide shows the overall cost-effectiveness summary results for the GSK vaccine. We anticipate the GSK vaccine would have an incremental cost-effectiveness ratio of $167,000 per quality-adjusted life year gained if given to a population age 65 and older, but have an incremental cost-effectiveness ratio of about $373,000 per quality-adjusted life year gained if given to that younger population in the age group 60 to under 65. Now I'd like to move on to our sensitivity analyses. We'll first see some tornado diagrams where we vary each parameter one at a time to see how they influence the cost effectiveness of vaccination. Then we'll examine how age and vaccine cost affect cost effectiveness. And finally, we'll examine those scenario analyses with varying vaccine efficacy duration. So on the next slide, we're showing our graph showing the top 10 most influential parameter assumptions that affect the cost effectiveness of the Pfizer vaccine. On the left-hand side, you can see individual parameter names, and the colored bars in the middle show how each parameter can affect the incremental cost effectiveness ratio. Recall that the base case incremental cost effectiveness ratio for the Pfizer vaccine was about $95,000 per quality adjusted life year gained. The light blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter was lower, and the dark blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter were higher. As you look at the top bar, you can see how the vaccine cost might change the results. So if the vaccine cost were lower at $180 per dose, the cost effectiveness ratio would be about $81,000 per quality adjusted life year gain. If the vaccine costs were higher at $340 per dose, then the incremental cost effectiveness ratio would increase to $188,000 per quality adjusted life year gain. For many of the other parameters, if the value is higher, the incremental cost effectiveness ratio would drop. For example, if the incidence of RSV hospitalization were higher, then the incremental cost effectiveness ratio would drop to $48,000 per quality adjusted life year gain. The most important parameters are those related to vaccine cost, RSV incidence, vaccine efficacy, and the cost of RSV disease. Our next figure shows the same tornado diagram, but for the GSK vaccine. Let's take a look at that one. The most important parameters are similar here. They're also those related to RSV incidence, vaccine efficacy, vaccine costs, and cost of RSV. Some important parameters I want to highlight here are the incidence of RSV hospitalization and vaccine cost. If the incidence of RSV hospitalization were higher, or the vaccine costs were lower at $180 per dose, then the incremental cost effectiveness ratio would drop below $100,000 per quality adjusted life year gain. The next slide shows how vaccine cost and changing the population that's vaccinated would affect the cost effectiveness of the Pfizer vaccine. The solid angled line shows how vaccine cost affects the incremental cost effectiveness ratio when applied to a population aged 65 and above. The top dashed line, angled line, in red represents vaccinating individuals aged 60 to under 65. We can see vaccinating the younger age group is less cost effective or more expensive. We can also see a lower cost vaccine would be more cost effective. The blue dots on the vertical dashed line represent the base case cost of a $200 vaccine. The next graph shows the same information but for the GSK vaccine. We can see a similar conclusion that vaccinating the younger age group is less cost effective. The red dot here represents the base case cost of the $200 per dose cost of the vaccine. Now I'd like to look at some different scenarios with varying the duration of efficacy for the vaccines on the next slide. As a reminder, these graphs show how our varying assumptions about the long-term efficacy. In the shorter duration scenario, we assume vaccine efficacy immediately drops to zero following the median time observed in the trials. And in the longer duration scenario, we assume efficacy declines to zero over a longer time period, finally reaching zero efficacy 36 months after the initial vaccination. On the next slide, we show a graph showing several angled lines representing the different durations of efficacy assumptions for the Pfizer vaccine. The solid line in the middle represents the base case duration of efficacy where efficacy declines to zero in 24 months. The shorter duration efficacy is the top dotted line, angled dotted line, and the longer duration efficacy is the lower angled dotted line. The large blue dots represent the vaccine cost of $200. With a shorter duration of efficacy assumption and a $200 cost of the vaccine dose, the incremental cost effectiveness ratio rises to over $135,000 per quality adjusted life year gain. But with a longer duration of efficacy out to 36 months, it would drop the cost effectiveness ratio to about $66,000 per quality adjusted life year gain. On the next slide, we show the same results, but for the GSK vaccine. The shorter vaccine efficacy assumption slightly raises the incremental cost effectiveness ratio. That's the dotted line slightly above the solid line. But the longer duration efficacy is the lower dotted line, and that lowers the incremental cost effectiveness ratio to about $131,000 per quality adjusted life year gain if that vaccine stays at that $200 cost per dose. Finally, on the next slide, I want to highlight some of the limitations of our analysis. The model structure does not contain varying risk groups besides age. This analysis is for a general older adult population. The model does not include dynamic transmission, so the vaccine does not reduce population transmission of RSV in this analysis. Additionally, models like this are always a function of the underlying parameter assumptions, and we have many uncertain inputs, especially for a new vaccines like these. We're uncertain what the actual vaccine costs will be for payers. We don't have perfect information about RSV incidence, and we lack data on long-term efficacy. On the next slide here, I just want to summarize things. The RSV vaccination for a population age 65 and above is potentially can be cost-effective, but can depend on many factors. First, the vaccine cost could cause the incremental cost effectiveness ratio to vary between $80,000 and $220,000 per quality adjusted life year gain. Incidence of RSV hospitalization can also affect the cost effectiveness ratio, varying it between $50,000 and $230,000 per quality adjusted life year gain. Vaccine efficacy variance there could cause the incremental cost effectiveness ratio to vary between $80,000 and $270,000 per quality adjusted life year gain. These ages recommended for vaccination could vary the cost effectiveness ratio between $50,000 and $370,000 per quality adjusted life year gain. And the duration of efficacy could also cause that incremental cost effectiveness ratio vary between about $80,000 and $170,000 per quality adjusted life year gain. So really under certain conditions, RSV vaccination could be more or less cost effective. And with that, I'd like to thank you for your time here, and I'm happy to answer any questions you might have.
Thank you, Dr. Hutton. And as a reminder, we're going to have Dr. Ismael Ortega-Sanchez present after this comparing this model to the other models. So any questions will be related to this particular presentation. Dr. Paling.
So thank you for this update and the important analysis that you did in showing how it can vary, the results vary with various parameters. On your summary slide, I just want to make sure I'm understanding this correctly. So under all conditions, we improved health, and the cost effectiveness analysis shows that it's never cost savings, but this is the cost for that improved health. Is that a correct interpretation of the results? Thank you.
Yes, this is how much we're paying per quality adjusted life year gain. And you're right, we're in all these scenarios we are improving health, but the costs are the cost of the vaccination intervention does not pay for itself, but so it does add cost, and this is that net additional cost we're paying per quality adjusted life year gain.
Thank you, Dr. Lair.
Thank you. I just want to say thank you for an excellent presentation. It was very clearly presented, and I got a lot of information out of it. So thank you very much.
Thank you.
Thank you. I don't see any additional hands raised. Just one last note of thanks, which is I really appreciate the number needed to vaccinate. I think those figures are incredibly helpful in addition to having the context of the cost effectiveness analysis. So we'll be referring back to those, I'm sure, at some point. With that, since there are no additional questions and no hands raised in the chat, we'll move on to Dr. Ismael Ortega-Sanchez, who will be presenting on the comparison of cost effectiveness results of the CDC model and each of the manufacturer models from Pfizer and GSK.
Thank you. Good morning. This is the updated story of 2 candidate vaccines and 3 models. This is the economic of vaccinating older adults in the United States against RSV. My name is Ismael Ortega-Sanchez. I'm a senior economist at the NCIRD. And this morning, I will attempt again to compare and summarize key elements and findings of 3 also updated economic studies. These updates have been discussed within the RSV ACIP working group. Next slide, please. 2 of these studies have been conducted by the manufacturers, updated studies of candidate vaccines. The first study was conducted by GlaxoSmithKline and his collaborators. And the second study was by Pfizer model. Pfizer is manufacturer of the bivalent RSV PrEF vaccine, GSK's adjuvant RSV Pre-3 vaccine. The third is an analysis led by Dr. Hutton. You just heard him presenting his findings. And for disclosure, I want to say that I was part of the team that helped to put together that study, or for full disclosure. Next slide, please. The starting point of the 3 economic models is the policy question regarding potential recommendations for the use of RSV vaccine in older adult populations. So the idea is to consider the economics of policy questions is to consider simultaneously the health benefits and the cost of vaccination. Namely, is vaccinating older adults against RSV cost effective? To answer this question, the 3 models use the same comparator and vaccinated older adults, and focus on analyzing the cost effectiveness of RSV immunization in this age group. Next slide, please. The policy question also defines key elements of the 3 economic models. Now, I want to emphasize one thing here for this and all slides to specifically identify changes and updates from those presented last February. The text will appear either highlighted, marked in red, or the word update will appear at the top of the slide or table. In this specific slide, the elements related to the modeling approach remain the same, but some inputs were changed, as shown with the highlights, specifically the incidence of RSV disease, some rates and outcomes, some direct and indirect costs. Some direct costs, in fact, were changed, specifically in the CDC model, and the intervention, the vaccine efficacy, duration of protection, safety, and program costs have been changed. We will discuss in detail these specific changes as well as the effect of these changes in the results. Next slide, please. In general, the three models still follow similar designs. Namely, they all use a static analytical decision-making approach, relied on probabilistic or deterministic sensitivity analysis to manage the various data uncertainties. Model a hypothetical cohort of United States 60 and older or 65 and older adults. But there have been changes, mainly due to the new data on longer duration of vaccine efficacy. The time frame was redefined. In this case, now it's 2 years, and in one of the analyses, more than 2 years after a dose of RSV vaccine has been applied. Next slide, please. The three models were updated, as you can see by the marks in red on the right-hand side. Once they updated, were fed into the model in the core model. Across the models, the sources, specific values, and assumptions of these parameters have some overlaps, but they were markedly different in some of the instances. For your consultation, we can provide a full report of this input data and assumptions. Back to this slide, the boxes are listed, the standard outcomes estimated and reported by the three models. Next slide, please. Back in February, this slide summarized the outcomes reported by the three models. At this point, I want to restate that the CDC model, as you have seen, is not one but two models in one, meaning that using data of vaccine efficacy, safety, and vaccine price provided by each manufacturer, the CDC model reports separate health and cost-effectiveness outcomes for each vaccine. As shown here, the manufacturer's main outcomes when compared to those of the CDC model show significant discrepancies in February. Next slide, please. As you can see, those discrepancies still persist. Note that the CDC model attempts to control the vaccine price uncertainty by aligning their price input with each specific price value used by the manufacturer's models. Even though the CDC model assumes the equal vaccine cost per dose for each vaccine, the resulting cost per quality are still much higher than those of the GSK and Pfizer. Specifically, the CDC estimates are about 3 times higher than those of GSK and about 4 times higher than those of Pfizer for either the adult 60 and over or 65 and over strategies. Next slide, please. To understand these persistent discrepancies, we try to identify and present the sources of these differences in this and the following 3 slides. Here, the CDC model provides a one-way sensitivity analysis for each vaccine. These tornado figures help to identify and rank the most influential input variables from top to bottom. The solid vertical blue line describes the base case cost per quality value, and each horizontal bar represents an input variable in the model. You can see that the size and direction of the horizontal bars describe the influence of each input when either it's higher or in orange or lower in blue values are used instead of the base case value. Note that either in the first figure, in the Pfizer, I want to emphasize that either in the first place or in the third place is ranked the vaccination cost. And as was shown before, hospitalization rates comes also at the top. Also ranked high is the vaccine efficacy for hospitalization for both models. Next slide, please. In a similar fashion, GSK model reported an updated tornado figure with the most influential variables. This figure focused on 11 top most influential variables. Among these variables are RSV RI incidence and the waning rate for BE for RSV LRTI. In sixth place appears the vaccine costs, but there are a number of other elements that have been updated regarding the vaccine, the waning of vaccine efficacy and the rate of hospitalization, or the proportion of those who are hospitalized amongst the RSV LRTV. Next slide, please. Pfizer does also report one-way sensitivity analysis where the most influential variables are identified. Unlike in February, at the very top is vaccine price, followed by the vaccine efficacy against hospitalization. Note that other epi variables like the outpatient rate or case fatality rate are not ranked anymore as influential as they were, I think, back in February. Next slide, please. Again, from the tornado figures, the common influential variables could be grouped into these three categories. The RSV rate of hospitalizations comes as one of the most influential, aside from the vaccine price that we are going to be discussing later on. Although GSK and Pfizer did not change the RSV hospitalization rate that they use in the base case or sensitivity analysis, this input remains quite influential. On the other hand, CDC updated this input basically using the crude surveillance rates that were hourly adjusted, and we will be able to see specifically how this impacts in the estimates. Also, another important input that has been changed, and in fact that's the most important one that we will be looking today, is the initial vaccine efficacy and waning over time. Here we have sort of like small sentences that describe these changes, but we're going to be able to focus on them very carefully. Among the costs, as Dr. Hutton mentioned, the CDC updated part of its costs basically by introducing some after-release medical care that changed some of the values upwardly. Next slide, please. If we look closer within them, we could still see marked difference in the rate of hospitalization and on-patient illness, as well as the unitary medical cost of hospitalization. As shown in this table, the hospitalization rates and medical costs as input data points used in the Pfizer model are on the high end, while those using the CDC model are on the low end, even with the updated values by the CDC. Except for the rates of outpatient illness, the GSK hospitalization and cost input values are somewhere in the middle. Again, the committee should bear in mind that the higher these input values are, the lower the incremental cost-effective ratios would be, or what is equivalent, the more cost-effective a vaccination program will look like. Next slide, please. It is important to explore a little bit more about the rate of hospitalization, and as we understand that it's quite influential variable as seen in the tornado diagrams, but also the input variables with more uncertainty as recognized by the working group and members as the manufacturing models. Moreover, there seems to be an inverse correlation between the cost per quality as reported in this figure using the CDC model and the hospitalization rates in the axis. Base case for Pfizer and GSK are shown with blue and orange solid filled diamonds markers, respectively, and for the base case hospitalization rate of 162 per 100,000 population. The blue balls markers were estimated using Pfizer vaccine efficacy and price input data for the specific hospitalization rates as reported by the reference. Likewise, the orange ball markers were estimated using the GSK vaccine efficacy and price input data for the specific hospitalization rate as reported in the reference. For both in the GSK component and the Pfizer component of the CDC model, it shows the inverse relation between the cost per quality and the RSV hospitalization rate. It also shows that for the scenarios to the left of the base case cost, the cost per quality is higher relative to the base case and lower on the right-hand side. Next slide, please. Such correlation could be illustrated by the dotted line connecting the cost per quality estimates for each vaccine. All the other alternative scenarios fall on the nonlinear trend corresponding to each vaccine. Though they do it at a different level, in general, for the same source of hospitalization rates used in the model, the cost per quality for GSK lies above of the ones estimated for Pfizer. Next slide, please. When we place the cost per quality estimates reported by the manufacturers, as you can see by the open diamonds on the right-hand side, the two important details are important to mention here. The time frame for the base case scenario in the GSK relies not only in the higher hospitalization rate, 260,000 260 per 100,000, but also on 3 years of time frame along which it is assumed an important degree of vaccine impact. We will talk about this assumption later on. As we can see here, it's not exactly apples to apples, the comparison. Note also that the reported GSK cost per quality is off and below the trends. Also off and below the trend, though much closer to, is the Pfizer estimate of $19,000 per quality. Another important detail in the Pfizer model, the hospitalization rate, the 300 per 100,000 population, relies on an ongoing, unvetted, and published prospective study which adjusted RSV detection rates. The source is reported as Pfizer data on file. Despite these data are not yet available for review, their input value, the 300 per 100,000 population for RSV hospitalization rate, has still been selected for the base case. Next slide, please. When the time frame is aligned among these three models, namely when the GSK cost per quality estimate relies only in a 2-year time frame, the cost per quality value of GSK is much higher and closer to the value over the trend line estimated by the CDC model. That is for the 256 per 100,000 hospitalization rate. Now, one might think that each of these scenarios is equally likely. Each of the points described by the orange ball markers and the blue markers are equally likely. Yet it could be observed that the rates on the left of the reported cost per quality by the manufacturers are mostly from peer-reviewed publications in the last 10 years, while farther to the right, when we move farther to the right, the hospitalization rate is the higher the uncertainty can be seen. So it could be argued that considering these uncertainties, the quality of the data may be higher moving to the left than to the right. Now we're going to move to another component of the comparisons. Next slide, please. By focusing on the initial early peak of vaccine efficacy as one of the most important inputs used in the model, the three models have updated most of their initial or early peak vaccine efficacy, complementing season 1 data on duration of protection with season 2 are now available. The data in this slide will also help to understand what comes next with the duration of protection. Next slide, please. Although it's important how well the vaccine effectiveness starts in RSV season, it is much more important or much more significant how it performs during the whole season, or in this case, seasons. Back in February, with this figure, we try to illustrate the assumptions about duration of protection used by each model. They were based on data reported in the first season, about 6 to 7 months, observed from the phase 2 clinical trials. Also, we pointed why the time frame was truncated at 12 months, mainly because of the uncertainty beyond the 6 to 7 months of data available at that time. We also pointed out Pfizer assumptions and the impact of that assumption beyond the 12 months. Next slide, please. This figure is a preface of the 3 following slides regarding how the duration of protection is modeled by each model. The 3 models rely on new available duration of protection data from both vaccines trials that cover the first 14 months in the case of Pfizer or 18 months in the case of GSK. However, after these initial periods, the residual protection is based on assumptions and higher level of uncertainty, as intended to be shown by the pink shaded areas. The CDC model tried to minimize this uncertainty and its impact. Next slide, please. This slide reports the vaccine efficacy assumption of GSK, how it behaves across the time, the initial peak and the linear decay. Please note the changes in the duration of protection assumption from February to today are described by the dotted lines versus the solid ones for each outcome. In general, the area under the red and the purple curves have increased up and to the right, which will also increase the impact on the disease burden and on reduction of disease burden and the cost effectiveness of the intervention. It was used to weight the linear regression to the mean which was fitted to estimate and describe the disease protection of the first 18 to 20 months after vaccination. The duration of protection will reach 0% at 43 months for RSV or RTD, or at 34 months for RSV or ARI. Note that the blue vertical line is at the 18-month point, marking that the trial data used for the vaccine efficacy duration of protection to its left is qualitatively different or higher than those of the right, those on the right of this line, including the 19th and the 20th month data points, which do also come from the trials, but have lower quality of or higher uncertainty as pointed by the pink shaded area. Beyond the initial 18-month period, the assumption of B decay is extrapolated using the linear regression, though with higher uncertainty. Next slide, please. Likewise, this slide reports the vaccine efficacy assumption Pfizer uses with linear decay at different rates per period of time. Again, note that the changes in the duration of protection assumption for February versus the one that is used today are described by the dotted lines versus the solid blue and orange ones, or by health outcome. In this case, the blue vertical line is at the 14-month point, signifying that the vaccine efficacy data available for 14 months supporting the assumption of vaccine efficacy, and after that point, the vaccination is relying on assumptions. Beyond this point, again, to the right, the assumption of vaccine efficacy has a higher uncertainty as highlighted by the pink shaded area. Pfizer model assumes a linear decline reaches 0% vaccine efficacy at 24 months after vaccination. Next slide, please. In the case of CDC, we try to align using the updated vaccine efficacy data for season 1 and season 2 for each vaccine in a more conservative way. The CDC model has also updated its duration of protection assumptions, as can be shown in this figure. Specifically, the CDC model reports a stepwise approach. This is quite different than the one used in February, which was an exponential decay. Moreover, the assumption is specific to the reported vaccine efficacy. So there is one assumption for GSK and one assumption for Pfizer, as you can see in this figure. Yeah? And the difference in the duration of protection between GSK and Pfizer corresponds to the components in the model is shown in the pink shaded area, which is basically the 2 months, the months that are from 14 to 18 in terms of data available from the clinical trials. These are the assumptions regarding the duration of vaccine protection that have an influence in the estimates that we have seen in the summary some slides before. Next slide, please. In this slide, and using the CDC model, we try to we estimate the estimation of in the comparison of GSK and Pfizer vaccines. The number of estimates have been provided for different scenarios. The base case is reported a little bit below the middle of the table, and as we can see, compared to the base case, the societal cost per quality would be about 120% higher for GSK or 130% higher for the 60 and 64 subgroup. Yeah, that will drop to approximately the 4th place in the 2000 about 205,000 per quality in the GSK to 118,000 per quality for the Pfizer. When we include all, not only the 60 and 65, but all the 60 and over population. There will be a 65% increase to 75% higher in value when the lower of incidence for health outcomes is used. The lower incidence of RSV in adults more than 65 years old will impact approximately 65% increase in the cost per quality and 71% increase in the cost per quality in the Pfizer case. On the other hand, RSV incidence adjusted upward by the increased diagnosis of yield from testing in addition to the RT-PCR or respiratory specimens will reduce the ratio in about 50% GSK for the GSK or 40% for the Pfizer Pfizer component in the University of Michigan CDC model. Similarly, when reducing the vaccine price per dose to 180 per dose, the ICER will drop about 50% for GSK or 80% for the Pfizer from the base case value. These scenarios are presented in order to have an idea of what it will be the impact. And these scenarios are basically different than those were, in terms of estimates, are still preserving the 4-to-1 ratio or 3-to-1 ratio for each one of these vaccines compared to what has been reported by the pharmaceutical companies. Next slide, please. There were a number of limitations that could be identified. But we want here to highlight the factors that could be considered may result in overestimating the ICERs, means that underestimating the cost effectiveness of RSV vaccination. Among them are that all of the three models assume no indirect effects of vaccination. It means that there is no protection against RSV transmission. So the three models are static models that do not include the indirect effects of protection. Except for the CDC model, manufacturers' models do not include RSV-related medical costs incurred after discharge from RSV-associated hospitalization. Although we should emphasize that this increase in the medical costs have not proved to be significant, but at least it didn't appear in the tornado diagrams as one influential variable. Manufacturers' models do not include potential vaccine-associated serious adverse events. Unlike in the CDC model, is included. Serious adverse events in terms of quality of life impact, resource utilization, and cost associated with these hypothetical serious adverse events. Again, this didn't prove to be a serious component in terms of influential the ICERs of either of the vaccines in the CDC model. One key limitation is that vaccine efficacy beyond clinical trials follow-up time, in the case of Pfizer, 14 months, and in the case of GSK, 18 months, is unknown. And this is one of the most important places of uncertainty. Yeah? All the three models assume non-zero decline efficacy beyond the 14 or 18 months. Next slide. In conclusion, differences in key input among GSK, Pfizer, and University of Michigan CDC models explain differences in results. Basically, the annual incidence of RSV hospitalization and outpatient disease are the ones that drive the analysis and that drive the differences, in fact, and even with the updates that became a little bit closer in terms of rates. Initial and duration of vaccine efficacy is the key component, specifically when we have assumptions about what happens after the second season, yeah, and how it's modeled that. Selection of medical cost and data extraction approach becomes in third place. Yeah. Resultant ICERs depend heavily on assumptions and selection of input data. Adjustment approach of vaccine increase incidence rates of hospitalization, ER, and outpatient seem to be an important factor that also may explain the differences. And definitely vaccine costs are very influential. Overall, from the base case of the three models, we can assume that vaccination will significantly reduce RSV disease burden in older adults. The clinical data and the assumptions support the impact on disease reduction. However, economic value of RSV vaccine appears to be costly and could be cost-effective if there are a number of things that could be considered as affecting one. As we have seen, RSV incidence, related healthcare costs, initial vaccine efficacy, and duration combined with reasonable price vaccine will determine the cost-effectiveness value of RSV vaccination in older adults. Next slide. Let me finish this presentation by acknowledging my colleagues that helped me put together this presentation, and I will be happy to answer your questions. Thank you.
Thank you very much for that presentation. Dr. Paling.
Thank you, Dr. Ortega-Sanchez, for that presentation. One of the things that you highlighted was the importance of duration of immunity. And so I wanted to give both Pfizer and GSK an opportunity to share if they're going to look at vaccine effectiveness with one dose over 3+ seasons, and how are you going to do that? Thank you.
We'll see if our colleagues from GSK could speak to this, and then from Pfizer.
This is Dr. Friedland from GSK. Do you hear me?
Yes, we can. Thank you.
Thank you, Dr. Poling, for that question. In study 006, which I presented today, there is one arm that will be followed, who just gets one dose and will be followed for 3 seasons. So yes, we will be following for 3 seasons. And we will continue to do additional studies as well. We also have immunogenicity studies, which are following long-term immune response as well.
And could you remind us roughly how many was in that one arm for that 3rd season?
Well, we haven't received that 3rd season yet, but the patients who were re-randomized to placebo were about 5,000. So we have 5,000 subjects now who received 1 dose, and we'll continue to follow them in that study.
Okay, thank you.
Thank you. And next, our Pfizer colleagues.
Yeah, so we are following a subset of participants in the Renoir study who are going to be revaccinated after the equivalent to 1 year, and then another subset that will be revaccinated after 2 years. And as I mentioned before, this is immunogenicity. We're not doing effectiveness in these particular groups because they're too small to get enough cases.
Okay, my question is, are you going to follow anybody who received 1 dose over 2, 3, 4 years?
Yeah, so currently we are following subsets for 2 seasons only, except for this subset. But as a discussion today, we will take into consideration potentially following subsets for longer.
Thank you. Dr. Cotton?
I'd like to thank Drs. Hutton and Ortega-Sanchez for their hard work in this field, and we have gone over this data multiple times in the work group. One of the issues that's come up is that GSK recently changed what we had been working with for an estimated price. The price that we'd been working with for GSK had been about $150, and it was recently conveyed to us that now the price would be $270. I was wondering for both companies if the current prices we are working with for Pfizer, $200, and for GSK, $270 per vaccine, if those are the final prices, or if we could have more information, because in voting on this, I'd like to make sure that I do the right thing by the American public and know what we are estimating that we will be paying for. Thank you.
Yes, thank you. This is Leonard Friedland from GSK. Can you hear me?
Yes, please go ahead.
Thank you for that question. The final price of GSK's vaccine is still being finalized.
Do you have an estimated date of when we might know that information? And is it estimated to be significantly more than $270?
Again, the final price has not yet been finalized. We do not have a date when that price will be, but it will be shortly. The vaccine will be priced using a value-based approach, grounded in cost effectiveness, and it will ensure that the vaccine offers good public health value.
Dr. Gertman, could you comment from Pfizer, please?
Good morning. This is Donna Alpol from Pfizer, and I will be answering the pricing question. Similar to GSK, it's important to note that the list price for Pfizer's RSV vaccine has not yet been established. To support cost-effectiveness analyses as part of the U.S. CDC evidence to recommendation framework, Pfizer has provided to the CDC a price range of $180 to $270 with a base case of $200. Based on the updated cost-effectiveness results, we continue to expect our RSV vaccine to be highly cost-effective.
Thank you. Dr. Talbot?
I'd like to piggyback on Dr. Cotton's comment. And we are voting today at around 4:30. If you could please come up with a price before then, it would be incredibly helpful, because this is a huge part of what we do. And as I've said before, none of us buy a car unless we know how much it costs. So if you could actually talk and bring something back before 4:30, it'd be incredibly helpful.
Dr. Sanchez.
Thank you. I noticed that the issue of transmission, and we don't know, and I was wondering from both companies, they were monitoring for respiratory symptomatology, and do they have data on PCR positive RSV in the placebo versus the vaccinated group without, because the data that I was more lower respiratory tract infections. So is it having less total RSV or just, I'm wondering about infection with RSV without the lower respiratory tract disease to see whether that could affect transmission.
So this is Dr. Grimmer from Pfizer. As I mentioned earlier today, there were two particular RSV seasons. The first one because it was interseasonal, and the second because it came too early and actually finished too early as well. So what I presented today is data on 3+ and 2+, but we remain to have vaccine efficacy against RSV acute respiratory illness, which is about 65% for the end of season 1, so somewhere between 60 to 65%. I'm not sure, Dr. Sanchez, if I'm completely answering your question, but overall, the number, RSV was circulating in a lower frequency than prior RSV seasons, and we'll see if by this next winter we are returning back to the levels where we saw before the pandemic.
And Leonard Friedman from GSK. Similar in our trial, we do have data on acute respiratory infections, as would be expected. That efficacy is lower than as we go through gradations of severity through lower respiratory tract disease. And in particular, we're not following to evaluate for impact on transmission in this clinical trial.
Are there any additional questions? Oh, Dr. Sanchez, are you set? Okay. I just wanted to ask a couple of questions. Let's see. Let me go back. I do think the point made about the models incorporating potential serious adverse events, I realize it was not very influential in the CDC model, but the incorporation of those, particularly with the post-marketing requirements and the commitments and the manufacturer models, I think is an important point. And then I just wanted to comment that I appreciate the CDC model did incorporate additional sort of longer-term medical costs associated with infection. As we know, some of our older adults can be frail, and we don't always capture the full impact of those infections in the older adult population. One specific question I will have, and I don't know if it's answerable in the moment, but I do think it's relevant for the votes later today, is that the CDC model was able to at least break down to a certain degree the 65 and older from the 60 to 64 population. I especially appreciate the numbers needed to vaccinate. I think that's an incredibly helpful number for us in this context. It does not seem like that's broken down in the manufacturer models, and I realize that that's probably, this is an evolving conversation, but it is really hard to make a judgment about the impact in that age group without having those numbers available. So wondering if that might be something that could be produced or shared if that's available from the manufacturer models.
Yes, this is Leonard Friedman from GSK. Thank you, Dr. Lee, for that question. We do have data on vaccine efficacy against lower respiratory tract disease in participants in the 006 study who were ages 60 to 64. That efficacy for a single dose up through the end of 2 full RSV seasons is 81.5%, with the lower limit on the confidence interval 53 and the upper limit 94%.
Thank you. And just to clarify my question, Dr. Friedland, it was really around the benefit-risk balance. So how would you estimate the number needed to vaccinate, given that the burden is likely different in the 60 to 64-year-old population?
I have my colleague Liz La on the phone, who is from our economics team, and she's going to respond to your question.
Thank you.
Yep, thank you for the Thank you for the question, and hopefully you can all hear me here. So RSV, of course, results in considerable clinical and economic burden in all adults aged 60 years and older, including those aged 60 to 64 years. So our model estimates that vaccinating 60 to 64-year-olds, assuming the same coverage as for flu vaccines, would result in nearly 440,000 fewer RSV cases in that 60 to 64-year-old group. And the cost effectiveness model estimates that there would be an ICER of around $119,000 per quality gained.
Thank you. I don't know if our colleagues from Pfizer have an answer at the ready.
Yes, Dr. Lee, thank you. We have one of our modeling team members here for you.
Yes, the analysis for the 60 to 64 separated from the 65 and older could be performed.
Sorry, we heard the beginning part of that. Was there a second part that you dropped off?
No, just to repeat, the analysis for the 60 to 64 years old can be conducted.
Thank you.
And Dr. Lee, this is Dr. Leonard Friedland again from GSK. There was a question about adverse events in the economic model. In GSK's economic model, adverse events are included in our economic modeling.
Thank you. And does that include serious adverse events as it relates to some of the post-marketing requirements and commitments?
Indeed, it does.
Thank you. Any additional questions? All right, well, I'm anticipating more conversation in the next section. So let me see, hold on one second. I do see we have a moment where manufacturer colleagues can offer a comment. Dr. Friedland, is there anything else you'd like to add in 3 minutes or less?
Yes, there is. And before I give my comment, I also wanted to get back to Dr. Lair, who was asking about atrial fibrillation. So Dr. Lair, in the first 30 days after the first vaccination in study 006, when looking at new onset atrial fibrillation, there were 4 cases in Arexvy and 2 in placebo. As mentioned, there was no imbalance when we looked at the following 30 days. And in dose 2 of that trial, there was 1 new case of atrial fibrillation in the group that received Arexvy second dose. There were 4 cases of new onset atrial fibrillation in the placebo arm in that second full season. But I want to say thank you, members of the ACIP, for giving GSK the opportunity to make a brief statement. I'm Dr. Leonard Friedland. My remarks will be focused on the positive clinical and health economic data that have been presented today. Our clinical development program, 1 dose of Arexvy is safe and efficacious against RSV-associated LRD for 2 full seasons, including against severe RSV disease and in adults with advancing age and underlying comorbidities, as shown today. Overall, the total safety database now includes more than 19,000 vaccine recipients with more than 25,000 doses administered. Nearly 6,000 have received 2 doses. And it's reassuring that across all studies, there are no new cases of GBS, ADEM, or other neuroinflammatory demyelinating disorders with that additional exposure. Vaccinating older adults with Arexvy is cost-effective for both 65 and older and 60 and older populations across a range of model inputs and assumptions, indicating that the vaccine is a good public health value for all older adults. In addition to reducing RSV disease burden, including 60 to 64-year-olds in routine RSV vaccine recommendations, would also, most importantly, have health equity benefits. With no head-to-head studies or standardized case definitions for RSV disease, any comparison of clinical and health economic data that have been presented for each of the vaccines should consider differences in the clinical trial designs, different case definitions, as well as different follow-up periods. Higher vaccine efficacy estimates would be expected when looking at shorter follow-up periods, given the waning of vaccine efficacy over time. The clinical data that we presented today confirm the importance of accounting for longer follow-up periods. It's important to note that the vaccine prices used in the economic modeling are a range of estimates that have been submitted by the manufacturers. Please note there's a significant overlap between the price ranges submitted for the two models that were presented today. GSK will determine its final price shortly. We appreciate the work that CDC and ACIP are doing to improve the lives of older adults and to improve health equity. Thank you.
Thank you for your succinct statement, Dr. Friedland. I believe we don't have any additional statements for this section. So if our members will allow, we will go on to the last section, which is going to be a robust discussion led by Dr. Melgar from the CDC on our evidence to recommendations framework for RSV vaccination in adults.
Good morning. My name is Michael Melgar. I am one of two co-leads of the ACIP work group for prevention of RSV in adults. Today, I'll be presenting evidence to recommendations frameworks for use of two FDA-approved RSV vaccines in older adults. These two vaccines are manufactured by Pfizer and GSK. Next slide, please. Through evidence to recommendations, we'll discuss two policy questions for each vaccine. Should a single dose of Pfizer RSV pre-F vaccine rather than no vaccine be recommended for persons 65 years of age and older and in adults 60 to 64? Should a single dose of GSK RSV pre-F3 vaccine, which includes an adjuvant, rather than no vaccine, be recommended for persons 65 years of age and older, and similarly in adults 60 to 64? The work group was polled on these two age groups separately, and I'll present results for each. Here, I'll also emphasize that the policy questions evaluated pertain to a one-time dose only of each vaccine. Next slide, please. This is the evidence to recommendations framework used by ACIP to make policy decisions. It includes 7 domains. Next slide, please. Of which we will discuss 3 today. These 3 were the focus of discussions by the work group that have been updated since February. The February 2023 ACIP presentation on evidence to recommendations included content on all 7 of these domains. Next slide, please. Today, some components will be the same for both manufacturers and will only be presented once, while others will be manufacturer-specific. Manufacturer-specific data will be presented for benefits and harms and resource use. Next slide, please. While equity will focus on RSV vaccines broadly. Next slide, please. All right, so we'll begin with benefits and harms. Next slide, please. We'll approach this section one vaccine at a time, starting with Pfizer's bivalent vaccine. I'll present the grade summary reviewed by the work group, followed by an estimate of RSV attributable illnesses prevented through vaccination. Then I'll present the same for GSK's adjuvanted vaccine. Next slide, please. First, shown here is the PICO question. Both manufacturers enrolled adults 60 years and older in their large phase 3 trials. Data from all participants in this age group were included in grade. The intervention was either of the two vaccines under consideration. The comparison was no RSV vaccine, and the outcomes included RSV lower respiratory tract illness or disease, abbreviated here and henceforth as LRTI or LRTD, medically attended LRTI or LRTD, hospitalization for RSV respiratory illness, severe RSV respiratory illness requiring supplemental oxygen or other respiratory support, death due to RSV respiratory illness, serious adverse events, inflammatory neurologic events, including Guillain-Barré syndrome, and severe reactogenicity. Next slide, please. Before we delve into grade for each vaccine, I want to make a quick note regarding case definitions for LRTI and LRTD. Next slide, please. Case definitions for this outcome were not aligned across the two pivotal efficacy trials. Pfizer defined 2 co-primary trial endpoints, LRTI with at least 2 lower respiratory signs or symptoms, and LRTI with at least 3 lower respiratory signs or symptoms. However, GSK defined their primary outcome of LRTD as at least 2 lower respiratory signs or symptoms, including at least 1 lower respiratory sign, or at least 3 lower respiratory symptoms. And the candidate lower respiratory signs and symptoms are at the bottom of this slide. Next slide, please. For use in GRADE, the trial outcomes selected were Pfizer's 3-symptom LRTI and GSK's LRTD case definitions. These were selected for their clinical relevance and to approximate case definitions for which there exist RSV incidence estimates. It's important to keep in mind, however, that differences in these case definitions confound comparison of efficacy results between products, and that GRADE was performed to independently compare each product to no intervention, not to compare products to each other. Next slide, please. All right, so with that note, we'll begin with Pfizer's RSV vaccine. Next slide, please. Here are the vaccine efficacy estimates for the outcomes that can be considered benefits of vaccination. Pfizer's pivotal phase 3 trial was the source of data for all outcomes. Here, we included all available follow-up time from the trial, which for participants in the Northern Hemisphere includes a partial second RSV season. Notably, these estimates were calculated by CDC using the same methodology that was used by the manufacturer, which did not adjust for any covariates. And this included season 1 versus season 2 of follow-up. The mean follow-up time was 10.6 months under surveillance per participant. And I want to emphasize this excludes a gap in surveillance for RSV outcomes between season 1 and season 2. The efficacy against LRTI, a critical outcome, was 84.4%. However, the certainty was downgraded for indirectness because adults 75 years and older who were at greatest risk of severe RSV disease were underrepresented in the trial, as were adults with certain underlying medical conditions like congestive heart failure. Additionally, persons with immune compromise were excluded from the trial altogether. The efficacy against medically attended RSV LRTI was 81%. This was downgraded for indirectness for the same reasons. Efficacies against hospitalization and severe RSV respiratory illness were calculated, but were based on fewer than 5 events in the trial. Accordingly, the evidence for these outcomes was downgraded for both indirectness and imprecision. Death due to RSV respiratory illness was not graded because there were no events recorded in the trial. The latter 3 outcomes were considered important but not critical by the work group for making policy decisions. Next slide, please. At the February meeting, ACIP requested to see efficacy stratified by certain demographic variables. I'll show that here for the primary trial outcome used in GRADE, the 3-symptom RSV LRTI. Next slide, please. Pfizer was able to demonstrate statistically significant efficacy against RSV LRTI for adults 65 and older and adults 70 and older. However, the trial was underpowered to estimate efficacy in adults 75 and older. Next slide, please. Pfizer also demonstrated statistically significant efficacy in adults with at least one pre-existing comorbidity of interest. However, the trial was underpowered to estimate efficacy among adults with at least one cardiorespiratory condition. Pfizer did not assess the baseline degree of frailty of trial participants and therefore did not estimate efficacy in this group. Next slide, please. Pfizer also demonstrated statistically significant efficacy in adults with at least one, Here are the outcomes that are potential harms of vaccination. In addition to the pivotal phase 3 trial, an early phase formulation selection study also reported these outcomes. The pooled relative risk of serious adverse events, a critical outcome, was 1.04. There were no serious concerns in the certainty assessment. The pooled relative risk for severe reactogenicity events was 1.43. The certainty was downgraded for imprecision because the confidence interval for a measure of absolute risk included the potential for both benefit and harm. There were 3 reported inflammatory neurologic events within 42 days of study intervention. All 3 events occurred in the vaccine arm of the pivotal phase 3 trial. Because there were no events in the placebo arm, relative risk was not calculated, and the evidence was downgraded for imprecision. Next slide, please. Looking across all trials, not only those included in GRADE, there was a total of 3 inflammatory neurologic events within 40 days of vaccination with RSV pre-F among approximately 20,000 older adults. Next slide, please. Here is a brief synopsis of each of these 3 reported cases. Case number 1 occurred in a 66-year-old participant in the United States with onset 14 days post-vaccination. The case was reported by the investigator as Guillain-Barré syndrome, or GBS, with the highest level of Brighton collaboration diagnostic certainty, level 1. However, the workgroup consensus is that the clinical course with waxing and waning symptoms over months after the onset was more consistent with chronic inflammatory demyelinating polyneuropathy, or CIDP, which is a distinct clinical entity from GBS. Case number 2 occurred in a 66-year-old participant in Japan with onset 10 days post-vaccination. The case was reported as Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome, with Brighton collaboration level 4 certainty, indicating that while Miller-Fisher syndrome could not be ruled out, the case did not meet any level of the case definition. Our workgroup review concurred, calling the case possible Miller-Fisher syndrome, but other causes for the clinical presentation were also possible. Case number 3 occurred in a 68-year-old participant in Argentina. The case was reported as motor sensory polyneuropathy with axonal rather than demyelinating features. The participant reported that some lower limb symptoms preceded vaccination, with worsening 21 days after vaccination. And the site investigator impression was that the case was not associated with vaccination. The workgroup felt nonetheless that it was important that ACIP be aware of this case. The workgroup concurred with the diagnosis of undifferentiated motor sensory axonal polyneuropathy. Next slide, please. For context, here are published estimates of the background incidence of Guillain-Barré syndrome across the age spectrum in North America and in Europe. These estimates are independent of any specific exposure, including vaccination of any kind. Notably, the incidence of GBS increases with increasing age, highlighted in the red boxes. In a meta-analysis of 13 studies, the incidence among adults 60 and older ranged from approximately 2 to 3 annual cases per 100,000 population. In a surveillance study using CDC's Vaccine Safety Data Link, the incidence in adults 50 and older ranged from approximately 2 to 7 annual cases per 100,000 population, with variation by sex. Next slide, please. It's important to note, however, that no intervention is totally risk-free. For additional context, here are CDC and FDA estimates for the degree of increased risk of Guillain-Barré syndrome following vaccination with currently recommended vaccines. The data on the association between Guillain-Barré syndrome and seasonal flu vaccination are variable and inconsistent across flu seasons. If there is an increased risk of Guillain-Barré syndrome following flu vaccination, it is small, on the order of 1 to 2 excess cases, or additional cases rather, per million doses of flu vaccine administered. Regarding recombinant zoster vaccine, or Shingrix, manufactured by GSK, a vaccine safety data link analysis estimated 3 excess cases per million doses administered, though Shingrix is a 2-dose vaccine, and the estimated risk was 6 excess cases per million first doses administered, with no significantly increased risk following the second dose. Next slide, please. So, coming back to the Pfizer grade, in summary, the Pfizer RSV vaccine likely reduces RSV LRTI with moderate evidence. Pfizer vaccine also likely reduces medically attended RSV LRTI with moderate evidence. The vaccine may reduce hospitalization for RSV respiratory illness, but the effect is very uncertain. The evidence did not show impact on severe RSV respiratory illness requiring respiratory support, but again, the effect is very uncertain. The investigational vaccine results in little to no difference in serious adverse events when all events and organ classes are considered. The vaccine may increase inflammatory neurologic events with low evidence certainty, and the vaccine likely increases severe reactogenicity events with moderate certainty. There was insufficient evidence to evaluate the outcome of death due to RSV respiratory illness. Next slide, please. And the overall certainty of evidence is considered moderate. Next slide, please. All right, in addition to grade, the workgroup considered results of a mathematical modeling evaluation estimating the number of RSV illness episodes potentially prevented by vaccination with Pfizer's vaccine. I'll show those results in a moment. However, first, I'm showing here one of the key inputs used in this analysis. This is the age-stratified incidence of RSV hospitalizations per 100,000 population per year. These data are from RSVNet, managed by CDC, and these data are from 4 RSV seasons of surveillance, predating the COVID-19 pandemic. As has been shown before, the incidence of RSV hospitalization increases substantially with increasing age. and that includes even within the age range of adults 65 years and older, which is shown on the right side of this figure. Next slide, please. All right, here are the results of the modeling work evaluating the number of RSV attributable illnesses that may be prevented per million vaccinations with Pfizer's RSV vaccine. This was performed by our colleagues at the University of Michigan as part of the economic analysis that was just presented. As in the economic analysis, vaccine efficacy against RSV hospitalizations and deaths was assumed to be equal to efficacy against medically attended lower respiratory tract illness. Vaccinating 1 million adults 65 and older with a one-time dose may prevent approximately 25,000 outpatient visits, 2,500 hospitalizations, and 130 deaths over 2 RSV seasons. You can see that the numbers of prevented outcomes are lower for adults 60 to 64, especially numbers of hospitalizations and deaths. That's primarily because there is less existing RSV disease in that group at baseline for the vaccine to prevent, as we saw on the previous slide. Next slide, please. Lastly, Pfizer has been required by FDA to conduct 3 post-marketing safety studies, as noted in the product approval letter. These include a study to evaluate the risk of Guillain-Barré syndrome with expected completion date in 2029, as well as a study to evaluate the risk of atrial fibrillation due to a small imbalance in the number of observed cases in the main phase 3 trial, and a small study evaluating safety and immunogenicity of revaccination. Next slide, please. When asked how substantial are the desirable anticipated effects of Pfizer's vaccine among adults 65 and older, the work group responded that they were moderate, taking into account the burden of RSV disease in this age group and the clinical trial results. Next slide, please. And regarding the undesirable effects, the work group's majority opinion was that they were likely small. Next slide, please. When asked regarding the balance of desirable and undesirable effects, the work group majority opinion was that the comparison favors the intervention. However, there was a minority opinion that the balance was unclear. These work group members were concerned about the 3 reported inflammatory neurologic events in the main phase 3 trial, as it's hard to know from 3 cases if this is a true safety signal or random events. Next slide, please. So now, when asked how substantial are the desirable anticipated effects of Pfizer's RSV vaccine among adults 60 to 64, the work group responded that they were small or moderate. Next slide. As for adults 65 and older, the work group felt the undesirable effects were likely small in adults 60 to 64. And next slide, please. When asked regarding the balance of desirable and undesirable effects, there was no clear majority opinion for this age group. Some work group members felt that, as for adults 65 and older, the balance of benefits and risks favored the RSV vaccine, while others felt that the balance favored the comparison, which was no vaccine. Other work group members felt that sufficient safety evidence was lacking to make a determination and that the balance was unclear. Next slide, please. All right, moving on to GSK's RSV vaccine. Next slide, please. Here are the CDC vaccine efficacy estimates for the benefits of vaccination in grade. GSK's pivotal phase 3 trial was the source of data for all outcomes. We included all available follow-up time available to estimate the efficacy of a single vaccine dose, which for Northern Hemisphere participants includes a second RSV season. The mean follow-up time was 15.3 months per participant. Though the mean follow-up time was longer in the placebo arm than in the intervention arm, because follow-up time after a second dose of the RSV vaccine among participants who received it was excluded from efficacy calculations. The efficacy against RSV LRTD was 74.6%. However, the certainty was downgraded for indirectness because adults 75 years and older who were at greatest risk of severe RSV disease were underrepresented in the trial, as were adults with certain underlying medical conditions like congestive heart failure. Additionally, persons with immune compromise were excluded. The efficacy against medically attended RSV LRTD was 77.5%. This was downgraded for indirectness for the same reasons. Efficacies against hospitalization and severe RSV respiratory illness were calculated but were each based on only 6 events in the trial. The evidence for these outcomes was downgraded for both indirectness and imprecision. Death due to RSV respiratory illness was not graded because there were no events recorded in the trial. Next slide, please. As we did for the other vaccine, we'll show efficacy against the primary outcomes stratified by certain demographic variables. Next slide. Here are the manufacturer-calculated efficacy estimates for RSV LRTD with and without adjustment by season 1 versus season 2 in the trial. Estimates without adjustment by season were similar to CDC's estimates, while the adjusted estimates were 5 to 10 percentage points lower. GSK was able to demonstrate statistically significant efficacy against RSV LRTD for adults 65 and older and adults 70 and older. However, the trial was underpowered to estimate efficacy in adults 75 and older. Next slide, please. GSK also demonstrated statistically significant efficacy in adults with at least one pre-existing comorbidity of interest and in adults with at least one cardiorespiratory condition. Further, GSK used a gait speed test as a proxy measure for baseline participant frailty. Significant efficacy against RSV LRTD was demonstrated among adults classified as fit according to the gait speed test and among adults classified as pre-frail. However, the trial was underpowered to estimate efficacy among adults classified as frail, who are at the highest risk of severe RSV disease. Next slide, please. Here are the outcomes that are potential harms of vaccination. In addition to the pivotal phase 3 trial, an early phase dose selection study also reported these outcomes. The pooled relative risk of serious adverse events, a critical outcome, was 1.02, and the work group had no serious concerns in the certainty assessment. The pooled relative risk for severe reactogenicity events was 4.06, with a confidence interval that did not include 1. The work group had no serious concerns in the certainty assessment here either. Finally, the outcome of inflammatory neurologic events was not formally evaluated in grade because there were no events in the included studies. However, there were 3 inflammatory neurologic events reported in smaller phase 3 studies that were not included in grade. These trials were excluded from grade because they did not include an unvaccinated comparator group. Across all trials, there was a total of 3 inflammatory neurologic events among approximately 18,000 older adult vaccine recipients. Here's a brief synopsis of each of these 3 reported cases. Oh, apologies. Can we advance? Thank you. And one more. Thank you. Here's a brief synopsis of each of these 3 reported cases. Case number 1 occurred in a 78-year-old participant in Japan with onset 9 days post-vaccination. The case was reported by the investigator as Guillain-Barré syndrome with Brighton Collaboration Diagnostic Certainty Level 3, indicating lower certainty. Upon our review, the workgroup consensus is that Guillain-Barré syndrome is the likely diagnosis. Cases 2 and 3 were reported as acute disseminated encephalomyelitis, or ADEM, which indicates acute brain inflammation. One case ended in death of the participant. Both occurred in 71-year-old participants, both in South Africa, both at the same site, after concurrent vaccination with both the GSK RSV vaccine and standard dose seasonal influenza vaccine at 7 and 22 days post-vaccination, respectively. Our workgroup consensus was that ADEM could not be ruled out, but basic diagnostic testing for ADEM was not performed, and other diagnoses appear more likely. CDC received information last week indicating that the site investigator had updated the diagnosis in the fatal case. Rather than ADEM, the investigator diagnoses now include hypoglycemia and dementia. These updates were provided to FDA as well. Next slide, please. In summary, the GSK RSV vaccine likely reduces RSV LRTD with moderate evidence. The GSK vaccine also likely reduces medically attended RSV LRTD with moderate evidence. The vaccine may reduce hospitalization and severe RSV respiratory illness requiring respiratory support, but the effects are very uncertain. The investigational vaccine results in little to no difference in serious adverse events when all organ classes are considered. And the vaccine increases severe reactogenicity events with high certainty. There was insufficient data to formally evaluate the outcomes of death due to RSV and inflammatory neurologic events. Next slide, please. The overall certainty of evidence was considered moderate. Next slide. And finally, here are the results of modeling work evaluating the number of RSV attributable illnesses that may be prevented per million vaccinations with GSK's RSV vaccine. Again, here, efficacy against hospitalizations and deaths was assumed to be equal to that against medically attended RSV lower respiratory tract disease. Vaccinating 1 million adults 65 and older with a one-time dose may prevent approximately 23,000 outpatient visits, 2,300 hospitalizations, and 120 deaths over 2 RSV seasons. You can see that the numbers of prevented outcomes, again, are lower for adults 60 to 64, especially numbers of hospitalizations and deaths. That's primarily because there is less existing RSV disease in that group at baseline for the vaccine to prevent. Next slide, please. GSK has also been required by FDA to conduct 2 post-marketing safety studies, as noted in the product approval letter. These include a study to evaluate the risk of Guillain-Barré syndrome and ADEM with expected completion date in 2030, as well as a study to evaluate the risk of atrial fibrillation due to a small imbalance in the number of observed cases in the main phase 3 trial. Next slide. When asked how substantial are the desirable anticipated effects of GSK's RSV vaccine among adults 65 years and older, the work group responded that they were moderate. Next slide. And regarding the undesirable effects, the work group's majority opinion was that they were likely small. Next slide, please. When asked regarding the balance of desirable and undesirable effects, the work group majority opinion was that the comparison favors the intervention. However, there was a minority opinion that the balance was unclear. These work group members were concerned about the 3 reported inflammatory neurologic events in the main phase 3 or across phase 3 trials, as it's hard to know from 3 cases if this was a true safety signal or random events. Next slide, please. Now, for adults 60 to 64, the work group felt that the desirable anticipated effects of GSK's RSV vaccine were small or moderate. Next slide, please. As for adults 65 and older, the work group felt that the undesirable effects were likely small. Next slide, please. And when asked regarding the balance of desirable and undesirable effects, there was no clear majority opinion. Some work group members felt that as for adults 65 and older, the balance of benefits and risk favored the RSV vaccine, while others felt that the balance favored the comparison, no vaccine. Other work group members felt that sufficient safety data was lacking and that the balance was unclear. Next slide, please. All right, moving on to our next domain, we will discuss resource use. Next slide. The work group felt that RSV vaccination for older adults could be a cost-effective intervention, but that the cost effectiveness depends on several factors around which there is substantial uncertainty. Work group members felt that the uncertainty is chiefly driven by 1, the ultimate vaccine acquisition cost, which remains subject to change. 2, the annual incidence of RSV illness, particularly hospitalization. And 3, the duration of protection resulting from RSV vaccination in this population. Finally, the work group noted that vaccination of older age groups would be more cost-effective than vaccination of younger age groups due to the higher existing burden of RSV disease with increasing age. Next slide, please. All evidence taken into account, the work group responded that yes, or probably yes, both candidate vaccines could be reasonable and efficient allocations of societal resources if recommended for adults 65 and older compared with no RSV vaccine. Though the work group notes that this poll response is contingent on the current vaccine price assumptions that were provided by the manufacturers. Higher vaccine acquisition costs may quickly reduce the cost effectiveness of this intervention. Next slide, please. Under the same assumptions, the work group felt that probably no, neither vaccine was likely an efficient allocation of resources if recommended for all adults aged 60 to 64. Next slide, please. Finally, we'll discuss equity. Next slide. The work group discussed multiple equity concerns, including the fact that not all persons experience the same risk of RSV disease. Therefore, an RSV vaccine might increase equity by protecting those disproportionately impacted by RSV. However, if vaccine access or uptake is not equal, an RSV vaccine might decrease equity. The age groups in which the vaccine might be recommended were felt to have important equity implications. Next slide, please. First, the work group considered the impact on equity of a recommendation for RSV vaccination in adults 65 and older. Next slide, please. As was presented to ACIP in February this year, the work group concluded that RSV vaccination could increase health equity by decreasing RSV disease burden among persons from racial and ethnic minority groups and in persons with lower income. And I will not revisit the evidence today. Next slide, please. In addition, the work group considered the impact on equity of a recommendation for RSV vaccination in adults 60 to 64. Next slide, please. So now, this table shows median age of adults hospitalized with RSV recorded in RSVNet, stratified by race and ethnicity, over the season spanning 2015 to 2020. Next slide, please. You can see that Black, Hispanic, American Indian, and Alaska Native adults hospitalized with RSV were younger than adults overall. In fact, at least 50% of adults in these groups would not have qualified for RSV vaccination if there had been an age-based recommendation for adults 65 and older. Next slide, please. The reasons for the disparity in age across persons hospitalized with RSV is likely multifactorial. However, one reason likely contributing is the disparity in prevalence of chronic medical conditions by age and by race and ethnicity. These are data from the National Health Interview Survey from 1999 to 2018. The figure shows the prevalence of 1, 2, 3, or 4 reported chronic conditions by age among Asian, Black, Hispanic, and white U.S. adults. You can see that the estimated prevalence of any count of chronic conditions is highest among Black adults across the adult age spectrum. The red box is highlighting the age group 60 and older in whom RSV vaccines are currently approved by FDA. Next slide, please. One thing to note is overall prevalence of at least one chronic condition, which reaches 60 to 80% among adults 60 to 64 and reaches 70 to 80% among adults 65 to 69. Next slide, please. Also notable is that the curves are more separated from each other in the 60 to 69 age groups than in the oldest age groups. We'll take a closer look at that in the next slide. Next slide, please. As we saw, the disparity in prevalence is not the same in each age category. This figure shows the difference in prevalence of multimorbidity, which is defined as at least 2 chronic conditions between Asian, Black, and Hispanic adults when compared with white adults of the same age group. What we would observe is that the adjusted prevalence of multimorbidity diverged between Black adults and white adults beginning at age 35 to 39, reaching its maximum difference of approximately 10 percentage points at age 60 to 64, which is highlighted by the red box. Then converging to reach similar prevalence by age 80. This trend in older adulthood might reflect survival bias in those who are still included at age 80 and older. The age-based difference in RSV conditions means that many Black adults are at higher risk of RSV earlier in life. Next slide, please. In light of the earlier increase in RSV disease among certain demographic groups, the work group expressed equity concerns among adults aged 60 to 64 under a universal recommendation in adults 65 and older only. Certain underlying medical conditions that increase the risk of RSV disease are more prevalent at younger ages among persons from racial and ethnic minority groups. The earlier onset of high-risk conditions, in turn, increases the risk of RSV severe disease at younger ages. Next slide, please. One policy option that the work group discussed to address the varied risk of severe RSV disease among adults 60 to 64 is shared clinical decision-making in this age group. Ideally, this would allow adults in this age group who are at high risk of RSV hospitalization to be vaccinated and decrease age and age-based racial and ethnic health disparities. Prior experience with shared clinical decision-making might inform the expected impact on equity. On the slide here are a sample, next slide, please. On the slide here are a sample of the shared clinical decision-making recommendations that have appeared in the tables or notes of immunization schedules. These include pneumococcal vaccination, hepatitis B vaccination, meningococcal B vaccination, and HPV vaccination. Today, I'll share experience with hepatitis B vaccination, for which there are some data on impact of shared clinical decision-making in older adult populations. Next slide, please. In 2011, ACIP recommended hepatitis B vaccination for all unvaccinated adults with diabetes aged less than 60 But for unvaccinated adults with diabetes age 60 and older, ACIP recommended vaccination at the discretion of the healthcare provider. This recommendation was revised in 2022. Now, hepatitis B vaccination is universally recommended for all adults with risk factors for hepatitis B infection. However, the long-standing recommendation, which might be similar to one for shared clinical decision-making for over a decade, provides an opportunity to evaluate vaccine uptake among older adults. Next slide, please. The data on this slide are from a study of NHIS data from 2014 to 2018, looking at the proportion of persons aged 60 and older with and without diabetes that received 3 doses of hepatitis B vaccine. In the table, the first column shows race and ethnicity. The second column shows vaccination coverage among older adults with diabetes, and the third column shows vaccination coverage among older adults without diabetes. What you can see is that hepatitis B vaccination coverage among older adults with diabetes was suboptimal, even 7 years after the recommendation was made. It was no different from overall coverage among older adults without diabetes. Next slide, please. That being said, coverage may have been slightly higher among non-Hispanic Black older adults with diabetes compared to those without. Next slide, please. In another study of knowledge, attitudes, and practices among general internal medicine and family physicians regarding pneumococcal and HPV shared clinical decision-making recommendations, most physicians strongly or somewhat agreed that shared clinical decision-making required more time than routine recommendation and that it creates confusion. Only 40% of physicians knew vaccines recommended with shared clinical decision-making would be covered by most health insurance plans. Despite these drawbacks, 75% of family physicians and 66% of general internal medicine physicians agreed they were in favor of shared clinical decision-making because these recommendations give more flexibility in decisions around use of a vaccine. Next slide, please. Ideally, shared clinical decision-making would increase access to adults 60 to 64 with medical risk factors for severe RSV disease who are disproportionately from racial and ethnic groups impacted by RSV at earlier ages. However, limited evidence from prior experience with recommendations similar to shared clinical decision-making in older adults suggests this type of recommendation may not overall substantially increase uptake in the target population. However, without a recommendation in adults 60 to 64, those with medical risk factors for severe RSV disease would likely face additional barriers, including financial barriers to RSV vaccination, increasing health disparities. So in summary, RSV vaccination that includes both, next slide, please. RSV vaccination that includes both adults age 65 and older and adults age 60 to 64 under shared clinical decision-making would increase access for adults 60 to 64 with medical risk factors for severe RSV disease. These adults are disproportionately from racial and ethnic groups impacted by RSV at earlier ages. However, shared clinical decision-making does not ensure substantially increased uptake in the target population. Next slide, please. Overall, the work group felt that a recommendation for RSV vaccination among adults 65 and older would probably increase health equity, or that it would probably have no impact, considering the effect in adults who experience risk of RSV at earlier ages. Next slide, please. Regarding the impact on health equity of recommending RSV vaccination in adults 60 to 64, the work group opinion was split. Those who argued a recommendation in this age group would increase equity stressed the importance of extending access to RSV vaccination to those in this group at increased risk of severe disease. Those who were concerned it would reduce equity were concerned that in this age group, adults with already existing access to care and health insurance coverage would be more likely to receive RSV vaccination. These adults would likely not be primarily those in the target population at increased risk. Next slide, please. And next slide. These polling results indicate, these polling results include some that were presented in February that were not revisited during today's presentation. Among adults 65 and older, the work group felt that RSV disease is of public health concern. They believe the desirable effects of vaccination with both vaccines were moderate and believed that the undesirable effects were small, favoring the two interventions over no vaccination. They believe that older adults generally felt that the desirable effects of RSV vaccination were large relative to the undesirable effects, but they believe there was important variability among older adults in how they value these outcomes. The work group felt that RSV vaccines would generally be acceptable to key stakeholders, that both candidate products, or both RSV vaccines rather, would be feasible to implement, and that both could be a reasonable and efficient allocation of resources. They believe that equity would probably be increased by an RSV vaccination recommendation in this population, or that it would have no net impact. Next slide, please. Looking at a recommendation in adults 60 to 64, the work group responded with a few important differences which are highlighted. First, they believed that the desirable effects of vaccination were small to moderate, thereby making the balance of desirable and undesirable effects more unclear. They also felt that RSV vaccination in this age group was probably not a reasonable and efficient allocation of resources if extended to all adults in this age group. And the work group was split regarding the impact of a recommendation in this age group in terms of what impact it would have on health equity. Next slide, please. Both RSV vaccines demonstrated significant efficacy against lower respiratory tract illness caused by RSV among older adults over at least 2 seasons. However, the trials were underpowered to show efficacy in adults at highest risk of severe RSV illness, including the oldest adults in the age range and adults who are frail. The trials were also underpowered to show efficacy against RSV hospitalization, though efficacy against symptomatic illness may indicate efficacy against more severe illness. RSV vaccination has the potential to prevent considerable morbidity from RSV disease among older adults, particularly in those with chronic medical conditions and those who are frail. Next slide, please. On the other hand, a small number of inflammatory neurologic events were reported within 42 days after vaccination with each RSV vaccine. The clinical trials were not powered to determine whether these cases occurred due to random chance, so it's not known at this time whether there's an increased risk of Guillain-Barré syndrome or other inflammatory neurologic events. Post-licensure surveillance for both vaccine safety and effectiveness will be critical. Next slide, please. The work group noted pros and cons to the choice of age cutoff for an age-based recommendation. If a recommendation is made for adults 65 and older, the target population would be at greater risk of severe disease, and therefore the balance of risks and benefits of vaccination would be more favorable. It would also align with the age-based cutoff for certain influenza vaccines and pneumococcal vaccination. On the other hand, this selection would exclude adults 60 to 64, among whom certain racial and ethnic groups are impacted by RSV at earlier ages. If a recommendation is made including adults 60 to 64, there's the potential to prevent a greater total burden of disease, and it would increase access to persons in this age group with medical risk factors for severe RSV illness. On the other hand, persons 60 to 64 who are uninsured would have more difficulty obtaining vaccination, counteracting some potential gains in equity. Clinicians may be less willing to adopt a recommendation among adults younger than 65, and such a recommendation would be a less efficient allocation of societal resources, again, if targeting all adults in this age group. Next slide, please. I'll now present the work group's summary interpretations regarding both RSV vaccines. The work group responded similarly to questions about each vaccine, so results will be presented together. Next slide, please. For adults 65 and older, the work group majority opinion was that the desirable consequences of RSV vaccination probably outweighed the undesirable consequences in most settings. When considering a recommendation in adults 60 to 64, the work group opinion spanned a close balance between desirable and undesirable consequences to the desirable consequences probably outweighing the undesirable consequences. In both cases, there was a minority opinion that there was insufficient evidence to determine the balance of consequences. Next slide, please. The majority work group opinion was in favor of recommending both RSV vaccines for adults 65 years and older. However, there was a substantial minority opinion not to recommend either vaccine based on currently available evidence. These work group members were concerned about the population-level balance of benefits and risks, considering the uncertainty and the risk of inflammatory neurologic events balanced against the evidence of efficacy, which is lacking in key groups at highest risk of severe RSV illness, including hospitalization. They felt that it's imperative to demonstrate efficacy in these groups prior to making a recommendation. Further, some work group members felt that a post-implementation safety signal for inflammatory neurologic events, even if caught early, could undermine confidence in RSV vaccines and in vaccines more generally. Next slide, please. For adults 60 to 64, the work group was not supportive of a universal age-based recommendation because adults under 65 have lower incidence of severe RSV disease and therefore may benefit less from RSV vaccination. The work group felt that until additional evidence becomes available to determine the existence and magnitude of a potential risk of inflammatory neurologic events, RSV vaccination should not be universally recommended among adults 60 to 64, as the benefit might not consistently outweigh the unknown risk. The work group remained closely divided between supporting a shared clinical decision-making recommendation with individual risk guidance versus no recommendation. However, selecting between these options, some work group members who selected no recommendation did voice support for a risk-based recommendation with a specific list of qualifying conditions rather than shared clinical decision-making. This included a small number of work group members who voiced support for a risk-based recommendation for all adults 60 and older without an age-based component. Next slide, please. Taking into account the complex range of work group opinions, we propose the following language for 2 ACIP votes. First, adults 65 years of age and older are recommended to receive a single dose of RSV vaccine. And second, individual adults age 60 to 64 may receive a single dose of RSV vaccine using shared clinical decision-making, which is based on risk assessment. Regarding the second vote, additional guidance will be provided for clinicians to assist in individual risk assessment for potential vaccine recipients in this age group. My colleague, Dr. Amadea Britton, will present some of those details in a moment. Next slide, please. So with that, I want to thank my colleagues who helped develop this presentation, and I'd like to turn it to my colleague, Dr. Amadea Britton, after which there will be opportunity for questions and discussion from ACIP.
Hi, so you can just advance to the next slide. I think it should be the first of this presentation. Great. So I'm going to be briefly presenting on CDC's proposed clinical considerations for RSV vaccines in older adults. And these clinical considerations take into account the expert opinion of the work group, as well as CDC's Immunization Services Division and Immunization Safety Office. Next slide, please. The major categories of clinical considerations we will discuss today are considerations for shared clinical decision-making based on risk assessment among adults aged 60 to 64 years, timing of RSV vaccination for the 2023-2024 RSV season, co-administration of RSV vaccines with other vaccines, and lastly, considerations for vaccination in persons with immunocompromising conditions. Next slide, please. To begin, in the event that ACIP votes to recommend RSV vaccines in adults aged 60 to 64 under shared clinical decision-making based on risk assessment, it is important to note that for shared clinical decision-making, there is no default. The decision about whether or not to vaccinate may be informed by the best available evidence of who may benefit from vaccination, the individual's characteristics, values, and preferences, the healthcare provider's clinical discretion, and the characteristics of the vaccine being considered. Next slide, please. If shared clinical decision-making is recommended, adults who are at higher risk of RSV disease and who therefore may be more likely to benefit include, but are not limited to, persons with chronic lung diseases such as COPD and asthma, chronic cardiovascular diseases such as congestive heart failure and coronary artery disease, immune compromise, including individuals taking immunosuppressive medication, hematologic disorders, neurologic disorders, endocrine disorders such as diabetes, kidney and liver disorders, and other underlying conditions or factors that the provider determines might increase the risk of severe respiratory illness. In addition to those at increased risk due to underlying conditions, residents of nursing homes and other long-term care facilities may be at increased risk for severe RSV disease. It is important to note that this list is not meant to be exhaustive and that if shared clinical decision-making is recommended, the intention, as noted by the language highlighted in this box, please click, is meant to ensure those at risk, even if not explicitly listed here, have access to the vaccine. Next slide, please. Next, we will discuss timing of RSV vaccination for the 2023-24 season. An important reminder, RSV vaccination is currently approved as a single dose. Optimally, vaccination of eligible adults should occur before the onset of increased RSV activity in the community. However, the timing of the onset, peak, and decline of RSV activity varies each year, and RSV seasonality during the COVID-19 pandemic deviated from prior seasons. Next slide, please. On this slide, we see the timing of RSV seasons over the last 6 seasons, with Epi Week on the x-axis and weekly count of RSV hospitalizations on the y-axis. The turquoise arrow under the x-axis denotes the beginning of January each year. While the peak of hospitalizations was similar from 2017 to 2020, you can see that this seasonality was disrupted by the COVID-19 pandemic, and that the most recent season, shown in green, had a much earlier peak. Next slide. Given this variability, the ideal time to start vaccinating cannot be predicted in advance of the 2023-24 RSV season. Providers should therefore offer RSV vaccination as soon as vaccine supply becomes available and should continue to offer RSV vaccination throughout the RSV season to eligible adults who remain unvaccinated. And although we know there is protection against lower respiratory tract infection at least through a second season, there are insufficient data at this time to determine the need for and timing of potential revaccination. Next slide, please. Next, we will discuss co-administration of RSV vaccines with other vaccines. For this presentation, co-administration refers to receiving vaccines at the same clinic visit. In accordance with CDC's general best practice guidelines for immunization, co-administration of RSV vaccines with other adult vaccines is acceptable. This includes giving RSV vaccines simultaneously with seasonal influenza vaccines, COVID-19 vaccines, pneumococcal vaccines, Tdap, and recombinant zoster vaccine. If co-administering RSV vaccine with other vaccines, each vaccine should be administered at a separate anatomic site. Next slide, please. There are currently limited data available on immunogenicity of co-administration of RSV vaccines and other vaccines. In general, co-administration of RSV and seasonal influenza vaccines met non-inferiority criteria for immunogenicity, with the exception of the Flu A Darwin H3N2 strain after simultaneous administration of RSV pre-FF3 Arexvy by GSK, and adjuvanted quadrivalent inactivated influenza vaccine. Overall, however, RSV and influenza antibody titers were generally somewhat lower with co-administration. Additional studies on immunogenicity of co-administration of RSV with other adult vaccines are in process. Next slide. Co-administration of multiple vaccines at the same visit may increase reactogenicity. Only co-administration of RSV and influenza vaccines have clinical trial data currently available for older adults. Evidence is mixed on whether there may be increased reactogenicity with co-administration of RSV and influenza vaccines. Data are lacking on co-administration of other vaccines that might be recommended for people in this age group, such as COVID-19 vaccines, pneumococcal vaccines, Tdap, and the recombinant zoster vaccine, Shingrix by GSK, which notably contains the same adjuvant as RSV pre-F3 vaccine Arexvy by GSK. Post-licensure safety monitoring of co-administration of RSV vaccines with other vaccines will further inform co-administration guidance. Next slide. Lastly, we will discuss persons with immunocompromising conditions. There is no separate recommendation proposed for persons with immunocompromising conditions. We know that adults with these conditions are at risk of severe RSV-associated disease and death. They may benefit from RSV vaccination, but were not included in the clinical trials, so efficacy in this population is unknown. Persons with immunocompromising conditions, including those receiving immunosuppressive therapy, may have a diminished immune response to RSV vaccination. However, persons with immunocompromising conditions are included in the recommendation to receive RSV vaccine under shared clinical decision-making with risk assessment and in the universal 65+ recommendation, given the potential for significant benefit in this high-risk population. Last slide. So that concludes the presentation, and I think Michael and I are both now happy to take questions.
Well, thank you. First, I just want to say thank you for an excellent set of presentations. It was very clear, and this is a complex and complicated set of issues, so really appreciate how much attention and detail you've given to the presentations, while also somehow making it as succinct as possible. This presentation is now open for questions. Dr. Cotton.
Thank you very much to both of you for the amazing work that you have done. I have a question about clinical decision-making and what are the could you elaborate further on the chronic medical conditions known to increase the risk of severe RSV? Thank you.
Yes, thank you for the question. We do have some backup slides prepared for this question. In the evidence recommendations presentation, if we could go to slide 95. Perfect, thank you. So in RSVNet, among adults hospitalized with laboratory confirmed RSV, almost all, 94%, have at least one underlying condition, with nearly half having 3 or more conditions. Cardiovascular disease, chronic lung disease, and diabetes were the 3 most frequently identified conditions. These were among patients who had clinician-directed testing, and patients with underlying medical conditions might be more likely to be tested for RSV than those who don't have underlying conditions, but the proportion of patients hospitalized for RSV who do have comorbid conditions, we can conclude is very high. I think next slide. Certain chronic medical conditions are known to increase the risk of hospitalization when looking at the population. One condition that's been consistently associated with increased risk is congestive heart failure, or CHF. This slide with published RSVNet data shows population-based rates of RSV-associated hospitalization among patients with congestive heart failure in blue and those without in orange. Overall, 28% of hospitalized RSV cases had CHF, and hospitalization rates were 8-fold higher in patients with CHF compared to those without. This difference was most pronounced in adults younger than 65, with CHF conferring a 14-fold increased risk compared to those who were 65 and older, in whom CHF conferred a 3.5-fold increased risk. Next slide. Several other underlying conditions have also been associated with increased incidence of RSV hospitalization in older adults. This is a summary table from 2 surveillance studies estimating incidence of RSV hospitalization in a well-defined catchment population, Prasad et al. In New Zealand and Branch et al. In 2 sites in New York. This table is limited to results among adults 50 to 64, the age group immediately younger than the 65-plus group. In addition to congestive heart failure, other conditions associated with increased risk of RSV hospitalization in at least one study included chronic obstructive pulmonary disease, or COPD, asthma, end-stage renal disease, coronary artery disease, and diabetes. Notably, this is similar to the list of common underlying conditions identified in RSVNet. Next slide, please. Immunocompromised adults are also known to be at increased risk of severe RSV illness from RSV. The greatest risk is among lung transplant and hematopoietic cell transplant recipients, as well as other immunocompromised populations such as those receiving chemotherapy for hematologic malignancies. Incidence of symptomatic illness is very high in some of these groups. For example, in 2 prospective studies of lung transplant patients, the incidence of symptomatic RSV was 12% over a 2-year period and 16% over a single season, respectively. Severe outcomes are frequently seen in immunocompromised patients with RSV infection. Progression to lower respiratory tract illness is very common, and mortality is very high. In one study of hematopoietic cell transplant recipients, mortality was 26% in those with RSV lower respiratory tract illness. And next slide, please. Lastly, in addition to adults with chronic medical conditions, those living in long-term care facilities are vulnerable to RSV infection. RSV is a frequent cause of respiratory illnesses in this population and is well documented as a cause of severe outbreaks. In one study, it was shown that 13.5% of all residents of a single facility had symptomatic PCR-confirmed illness in a single month during an outbreak. RSV in long-term care facilities also contributes substantial disease burden and cost to the healthcare system. In an industry-sponsored study using Medicare data, the authors estimated that RSV hospitalizations among long-term care facility residents cost over $50 million over 6 years, with an average length of stay of hospitalization of 5.3 days. So that summarizes some of the literature regarding conditions and factors that increase risk of severe RSV disease.
Thank you for that very complete response. Dr. Brooks.
I really want to echo what Dr. Lee said. There's so many confounding factors but the reason we know them so clearly was because how well it was presented, both sets. So I mean, really, it just gets more challenging every meeting. Can you go, a critical issue obviously are the GBS cases or the ADEM cases. So can you go to, I think it's Dr. Britton's slide 42 that really broke them down. I think this is really important because there's an implication. Okay, so the one that had the 3 cases, I have it as slide 42 in that particular presentation.
We actually have a backup with all of them listed in one place.
Yeah, because there were 3 for each manufacturer. There is a backup slide, 111, that has clinical vignettes for all 6 in one slide. I think if you type in 111, enter, there you go.
Oh, good, good, that's even better. I was looking at the GSK, so 2 of the 3 cannot be ruled out, however, other likely causes. Unclear with the Pfizer. So I think that the main reason why there was concern regarding just a robust recommendation for at least 65 and older was because of the concern regarding this. So I guess the question is our concern reduced after there's a more detailed evaluation? In other words, there were these 6 cases, but maybe they're not really from the vaccine. So I don't even know who I'd ask to comment on that, but I just wonder, maybe the work group or someone, did you all have this information when you were doing your voting and your deliberation?
Yeah, thanks for the question, Dr. Oliver. So yes, the work group did have this information before them when considering the policy recommendations that were going to go before ACIP. We did include this in discussions a neurologist who is a member of the work group, and while I think it's very difficult to conclude based on these vignettes, the association between the illness onset and vaccination. What we can objectively say is that these cases occurred within a 42-day risk window after vaccination, or at least were reported as such. And in addition to that, though, there is substantial uncertainty in the diagnosis itself, and that varies case to case. I think you're right to point out that the 2 ADEM cases reported in the GSK safety data set do have a substantial degree of uncertainty in the diagnosis. And as I mentioned in the fatal case, which is the second from the bottom on this slide, the site investigator did recently, last week, update the impression of what diagnoses were assigned, updating it to hypoglycemia and dementia. So that information remains to be reviewed by FDA. That being said, though, I think that it's important to note that in both safety databases for each vaccine, there has been at least 1 case of either Guillain-Barré syndrome or chronic inflammatory demyelinating polyneuropathy, for which there is pretty high certainty in the diagnosis that had onset within 42 days after vaccination.
And thanks, that was a great answer, seriously. I appreciate that.
Thank you. Dr. Lair?
Thank you. I have 2 thank yous and 1 question. You might not have seen, many of us wanted to applaud at the end of your presentations. They were spectacular, and I consider them a gold standard for a presentation for helping us make the decision. Not only did they lay out all the issues well, they also were transparent about the minority opinions, which was really, really helpful. I've never seen such good equity slides, which gave a great comparison between the minority racial and ethnic groups and showing how much they have a higher incidence of disease. And your backup slides are amazing. So I want to say thank you to you. I also want to say thank you to the work group. I know a few people who are on the work group. I've spent several hours in the last week myself trying to go through all this data, and I can only imagine the amount of work that the work group had to do to come to these conclusions. So I want to say thank you to all of you. If you could go to slide 25, this is sort of the background rate of the hospitalizations. And if you look at 65 to 75, a quick estimate is about 100 to 300 cases of hospitalization per 100,000 adults, which is about 1 to 3. So I'll just use 2 as a reference number. So if you can go to slide number 14, it looks like the 4th row down, 3rd row down, the placebo group only had 3 hospitalizations for about 16,000 people. This seemed to be an incredibly anomalous season. It's about 10% of the number of cases you would have expected for hospitalization. And I'm wondering if that should have any effect on our decision, or do we just accept it as an anomalous season and sort of say we can extrapolate the data? Because that's just been bothering me for the whole week. Thank you.
Well, I do want to let the committee discuss that because there's no definitive answer. But for one thing, I do want to mention that my colleague, Dr. Amadea Britton, contributed substantially to the equity slides. So I want to make sure credit is assigned where it's due. I think maybe to provide context, we could go to slide 105 in the evidence to recommendations slides. So again, this was a slide that was also part of the clinical considerations, but this demonstrates the effect of the COVID-19 pandemic on observed RSV hospitalizations in adults 65 and older. And season 1 of these, both clinical trials coincided with substantially reduced incidence of RSV hospitalization in older adults, which in part likely contributes to the low incidence observed in the placebo group compared with surveillance studies, which date to before the COVID-19 pandemic. But that being said, I think that Dr. Lair's point is one that is important to bring up, and I would welcome other comments from the committee.
And Dr. Lair, I think this really highlights all those beautiful slides that talked about those who are at high risk for disease and for high risk for hospitalizations and death were actually not included in the trials. So it's very hard for them to see the number of hospitalizations we would expect when the patient population that participated in the study were younger and healthier and had fewer comorbid conditions, were not immunocompromised, and were not living in nursing homes.
Dr. Paling.
Okay, so I am so happy. First of all, my thanks to both Dr. Melber and Britton for a fabulous presentation and highlighting the challenging decision before us. Thank you to the work group because this is really challenging. I have a comment, and it's meant to be shared with all manufacturers and not just limited to this. And so what I wanted to highlight was how appreciative I was of the high-risk condition slides and by age, because that is really essential. And I appreciated your comment on showing the risk of RSV, Dr. Cotton, by conditions. And then Dr. Lair, I too was challenged by the number of hospitalizations and recognized the underpowering. So now I might get to my comment. The challenge is we are to make a recommendation for all U.S. Americans. And there's a desire to have your ideal patients part of the trial. The challenge is you're going to not see the hospitalizations and the significant effects if it doesn't reflect the population we're being asked to make a recommendation for. And I would like to highlight that this has been a challenge everybody's struggled with for years. But COVID-19 taught us that we can be inclusive and have fewer exclusions in trials and get the data we need in an efficient way. And I think we need to make sure all studies reflect the U.S. American population, and we have a population with a lot of comorbidities. Thank you.
Thank you. I'm going to take a pause for a moment and just ask if we can put the vote slide up. I'm going to try and ask our committee to move us towards a discussion around the vote language as you continue to ask your questions. And just really, sorry, I'm going to just interject briefly, which is that in some ways, this is also just about our values. So regardless of whether it's influenza, COVID, RSV, pneumococcal disease, we certainly want to prevent hospitalizations, ICU admissions, and death, but I think there's a lot of us that also just want to prevent the burden of disease that's out there because it actually it's the tip of the iceberg that we're often focused on, but not all of the individuals underneath that who are impacted by all of those diseases. And so it's also just a call for consistency.
But before we change the slide, is my understanding correct that the studies were done in 2021 to 2022? Yes, thank you.
Season 1 of the studies coincided with 2021 into 2022. Season 2 of the studies included the green peak with the higher incidence of RSV disease.
Thank you. I see Ms. McNally next.
Thank you. I have a few questions. I want to begin by asking if Dr. Ortega-Sanchez can clarify whether the manufacturer's models included potential serious adverse events.
Yeah, this is Ismael Ortega. There are a number of adverse events that were coming out from the specific clinical trials, but not all of them were included in the cost-effective analysis. In fact, there were considerations about moderate to severe or systemic adverse events that were reported. But when we were talking about serious adverse events, those were not exactly in the clinical trials models.
Thank you. And I think it's important for the public to understand how safety monitoring will work for GBS and ADEM because of the fact that the post-marketing safety study completion dates are so many years in the future. So I'm hoping that Dr. Shimabukuro can comment on that.
Hi, this is Dr. Shimabukuro, I'm the Director of the Safety Office. So when a vaccine is newly licensed and recommended, there's always a period of enhanced monitoring during the initial uptake phase, and that will include monitoring in the vaccine adverse event reporting system, a passive surveillance system, and also active surveillance in the vaccine safety data link, which I think most of you are familiar with. That looks at pre-specified outcomes and does sequential monitoring as the data come in. And then we also have our clinical immunization safety assessment project, which does clinical consultations at the request of healthcare providers. And I'll just mention that there are other agencies that are involved in post-licensure safety monitoring, including our colleagues at FDA and in the VA.
Thank you. And finally, I'm wondering if the American Geriatric Society has any comment on this issue.
Dr. Schmader?
Yeah, thanks a lot, Ms. McNally. The AGS wants to go on a record noting the results of the trials for older adults as encouraging vaccine efficacy and representative advance in the field, but the results are markedly limited by the marked underrepresentation of persons 80 and older who are frail, who reside in long-term care facilities. You know, these are all groups at highest risk for severe disease, and the types of patients we care for as geriatricians. And the studies don't provide evidence for prevention of RSV-associated lower respiratory tract disease in these groups, or evidence that the vaccines prevent change in functional status, hospitalization, ICU admission, or death. And we also believe that longer surveillance and larger sample sizes are needed for assurance regarding vaccine safety, especially regarding inflammatory neurological events. So, you know, AGS recognizes these as potential valuable vaccines, but we think it's premature to favor their use in the types of patients I just mentioned and the types of outcomes I just mentioned. And we look forward to more information on that. Thank you.
Thank you. We still have a few hands raised in the room, so I want to go to Dr. Long next.
So I was one of the work group members that was represented by dashes of concerns are unclear. And it really was based on three things. The lack of inclusion of the right people in the trials, concern for lack of boost, and safety. So the lack of the inclusion of the right people in the trials was nobody over 75 to speak of, not the frail folks who are most likely to have severe outcomes. And concern that I think we will not be able to recommend this to be given concurrently with any other vaccines, because although they met non-inferiority for most concurrent administrations, they were statistically significantly immunogenicity less than if they had been administered together. So what if we traded RSV for influenza? And there were more frail people getting influenza, et cetera. So that is the inclusion of the right people and concerns about that. The lack of the boost is really odd and concerning to me because it was a year later. We don't think there wasn't enough time for the immunologic system to try to say, I'm going to see this, I'm going to see it better. We did not see a typical, I'm sorry, I should say the GSK, which is the only one we've seen so far, was not associated with a typical boost in the sense of higher antibody and prolongation of that level. It looked like the decline curve was at least as steep after the first administration. And the second one was, it wasn't even additive, let alone it was not exponentially higher. So there's something maybe odd going on there. It is not plausible that there would be a mucosal infection that one could get a parenteral vaccine and be good to go for 5 years, let alone lifetime. Mucosal infections that we've given parenteral vaccines for, influenza, pertussis, and coronavirus. There's just not going to be. You basically have to leach out IgG antibody into your respiratory tract to get prevention. So my major concern is then, if this is not boostable, ever maybe, because 1 year is a pretty long time to wait to give a boost, giving it to people who are 65 without risk factors of age, older age, or risk factors of underlying disease, you may be protecting them at the age at which they're least likely to have the death or the severe outcome. And we don't know that yet. So I'm glad that Pfizer is studying that, and we may have some data on this next year because the vaccines are quite similar, although not identical. And the third is safety. So you're right, Dr. Brooks. If we had seen all these cases laid out in the work group first pass, would we have been so concerned about safety? I think I still would have been, because if we think about other vaccine and other vaccine trials, there were 6 cases of some type of neuroinflammatory disease in 42 days after receipt of one of these vaccines. In 3 of them, there were placebo 18,000 who did not have those events. So we have 6 cases of some type of neuroinflammatory disease in 40,000 people, maybe. So it is an almost outrageous number when we consider what the likelihood of that is in 42 days in someone's life. And so that I think the risk-based recommendations here would be unusual. It's not cost. I think that, although it's costly, for me it would be so that your risk of severe outcome or death would be high enough to warrant taking this vaccine that we're unclear about the neuroinflammatory events. And as far as equity is concerned, if we decided that people 60 to 64 of minority groups are at increased risk, I would hate to see the day that we worked out that neuroinflammatory disease was associated with this vaccine, and that we worked that out over disadvantaged minorities. That's my last.
So we really only have about 10 minutes left, so I just want to clarify, as it relates to the ACIP voting language up on the screen, do you have any I recognize the context of the comments, but is there particular concerns you have about the vote language as it's written on the screen? To my wordsmither, okay?
No, the wordsmithing,
Okay.
we already did all that.
Thank
We
you.
got two things in the second part,
Okay.
shared good claims
Thank you.
and risk.
I will say just really briefly on the second one, and this is a procedural issue, and this gets back to our prior conversations about adding qualifiers to the recommendations. It really should be shared clinical decision-making, and recognizing that risk assessment is a part of that shared clinical decision-making. That should really be embedded in the text of the recommendation if that is the case. But as a straight voting language, we should be clean about it, because I think it'll conflate risk-based recommendations with shared clinical decision-making based recommendations. And I do think we should probably be very clear about this. So I'm absolutely fine with the risks that were articulated being included in the text to support shared clinical decision-making, but I would recommend a wording change on the second to strike the risk assessment. Dr. Cotton, since you're chair, do you want to just comment real quickly?
Sure, just very quickly. I just had a couple of comments. One about the immunocompromised host and the data that, or the information that Dr. Britton reviewed. Again, this would only be used in immunocompromised patients over the age of 60. That wasn't necessarily entirely clear on the slide, so just for people who might be listening. Unfortunately, this vaccine is not yet approved for people under the age of 60. I fully understand as a representative of the immunocompromised host community that people might want it for people under that age, but thus far it is not yet approved. My second comment is that on concomitant vaccination with Shingrix and the GSK vaccine, both contain the same adjuvant. The GSK RSV vaccine contains a half dose of the adjuvant compared to Shingrix, but given the neuroinflammatory concerns that we are debating, along with the neuroinflammatory concerns seen in Shingrix, I personally do not believe that these vaccines should be given at the same time. I also clinically don't think that there's urgency to give RSV and Shingrix in the same clinical visit. So I personally would recommend, and I will recommend to my patients, that those not be given at the same time. The other issue is that we did consider given issues around the lack of increased vaccine efficacy with boost, et cetera, and multiple other concerns and thoughts, we did have some thought about making a recommendation for adults 65 years of age and older to have this vaccine with shared clinical decision-making. And we had pondered that. I do want to express concern for that approach, given that this may well end up being Medicare Part D. We don't know yet. But if that were to be true, then shared clinical decision-making would be in the realm of pharmacists and would put a lot of weight onto that system. And I do worry that that might result in compromise in efficacy and vaccine delivery and multiple other topics. So we did think about that, but that is one of the things that shaped my thinking about this. Thank you.
Thank you, Dr. Cotton. That was very helpful. Dr. Daly and Ms. Mata, just quick questions if we can.
Yeah, a number of the points that I was going to bring up were brought up by Dr. Long and by Ms. McNally. But Dr. Cotton, could you elaborate on shared clinical decision-making over age 65 and who's having those conversations? Sort of the work group conversation about drawback of that approach. Thank you.
So I think it's a good question as far as, and I don't know that we actually have data showing who is having those conversations with people over the age of 65. We do know that many people don't have full access to their clinicians or to people who would be having a good conversation with them. So I do worry that that would be a potential compromise for people 65 and over who are clearly at higher risk for severe life-threatening RSV infection. We have concerns procedurally about vaccine rollout, as I mentioned, as far as who would be having the conversations. I know that, in my clinic, I can't actually give Shingrix. I need to tell people to go to a commercial pharmacy for that to be administered. So the minute that it can't be done easily in one visit of any type, I think that decreases the likelihood that vaccine will be given. But again, this is sort of like the cost issues, which remain quite opaque and is very concerning to me as well. How vaccine delivery would occur is also not yet clear. So I do have concerns about that, and that helped frame my decision-making.
Thank you. We're going to go to Ms. Bata, and then we're going to have to take a break after this, but we're conferring and decided that we'll come back early from our break to continue the discussion, because I think it's really important that we make sure we get all the issues on the table. So Ms. Bata, and then off to break. And for those who are liaison colleagues, we will get to you after the break.
I had similar thoughts as Dr. Daly. I kept thinking, without the information that we really need in terms of our at-risk population, even 65 and older, not being included in these, I would be more tempted to do a clinical-based decision-making for all the groups because we don't have that information. And I definitely think that we need to consider the 60 and above.
Thank you, Ms. Bata. All right, thank you, everyone. We are now back from break, and we'll reconvene the ACIP meeting. Just going to give everyone 30 seconds to sit down, and then we'll get started. So as a reminder, we are back to adult RSV vaccines. We wanted to continue the conversation that was happening. I have asked the team to put the proposed ACIP voting language. Those are two separate votes, just of note up on that slide, so we can continue the conversation. Let me just double check. Let me check to see whose hands are raised in the room. Dr. Sanchez.
Thank you. Just a few comments as well. First of all, I was impressed with the low rates of serious illness in these studies. Very few hospitalizations, very few requirement for oxygen. I also was disappointed that overall there was no data on less severe disease and looking at transmission, ultimately to see if this vaccine can prevent infection, not just a disease, which I doubt that it will prevent infection, being a mucosal infection. But when I look at the the recommendation, I'm torn about making a universal recommendation for 65 years of age or older for everyone. And I'm really leaning towards more of a risk assessment, even given that, unfortunately, the study did not fully enroll as many of those individuals as I would have liked to have seen. But and on a personal note, I'm 68. I'm not sure if I would take it myself. So without not having other comorbidities. So I'm torn by it. I actually was reassured to some extent by the neuroinflammatory, the explanations of the cases for the neuroinflammatory conditions that were the 6 cases that were reported. Thank you.
Thank you, Dr. Sanchez. Dr. Bell.
Yes, thank you. I just wanted to make a couple of comments myself, which are pretty consistent with what we've been hearing. First of all, to the point that you made, Dr. Lee, and Dr. Talbot, the idea of trying to make a recommendation, taking into consideration this beautiful cost-effectiveness analysis, having no idea, essentially, of what the cost of the vaccine will be, is just really very frustrating and unfortunate, and makes it difficult for us to do our job as well as we would like to. And clearly the manufacturers know this, but it would be really lovely if something could improve on that topic. Second is the issue of the study populations in the randomized trials. And again, as others have said, the populations that are at highest risk for severe disease were not included in the trials. And I think that the COVID-19 vaccine experience showed us that it is possible to do clinical trials that include people who have comorbidities. And if I remember the proportion correctly, it was 94% of hospitalized people with RSV have a comorbidity. So we don't have any data about the population we really want to get vaccinated. So that's also quite difficult. Third, I think this issue of the lack of boosting is very perplexing. I certainly don't understand it, but it is a little bit worrisome. So for those reasons, I wanted to, I also am kind of feeling a little bit uncomfortable about a recommendation rather than shared clinical decision making, even in people 65 and older. But I wanted to ask Dr. Cotton again. I missed what you said about the implications of shared clinical decision making with respect to Medicare. And if you could repeat that, that would help with what, as we've all said, is a really very difficult decision. Thank you.
Thank you, Beth. It's Camille. So I don't think we know yet what exactly will happen, but my general understanding is that if we say shared clinical decision making for 60 to 64, that insurance would end up covering that, and I'm getting some head nods. And then for people 65 and up, if it's, I think, either a recommendation, but it may be, and my understanding is that this is determined at a later date after ACIP recommendations are made, but that it could be Medicare Part D, and that it would not be necessarily readily available in doctors' offices and in clinics and whatnot, but that it might be more available through commercial clinics. Perhaps maybe Dr. Lair could comment on that and his experience.
So this is Jamie Lair in private practice. Medicare Part D vaccines can be given in private this is Jamie Lair, private practice. Medicare Part D vaccines can be given in private practice with a fair amount of rigmarole. I will accept and appreciate that once it has been approved, there have been no copays recently, and that's actually been very helpful. But I have to get prior approval to get the vaccine, and this is specifically the Shingrix vaccine and the Tdap vaccines for Part D. For Part B, they are automatically allowed to be given in the private practice.
Thank you for that. And so that seems to be a major barrier towards large-scale vaccine delivery, and would also be a significant issue against equity, in that not everyone has access to healthcare providers who could help them with shared clinical decision-making. And that's why, although I had contemplated that recommendation for people over the age of 65, I think that it would actually end up being a tremendous barrier towards vaccine availability for many people who would be at high risk for this vaccine. Beth, I hope that answers your questions.
Yes, it does, but I just wanted to say one other thing then. Would it be possible, Dr. Lee or someone, would it be possible for someone from Medicare to at least tell us what criteria they use for deciding which vaccines are in Part D and which ones are not? I mean, it's sort of a last-minute thing and perhaps not feasible, but it would be nicer if we had some information about what the likelihood would be that this vaccine would end up in Medicare Part D. Thank you. That was very helpful.
Beth, it's Camille again. We agree with you, and we actually have someone from CMS who is extremely well-versed in this on our work group, and it's been really, really helpful working with him. And so far, our understanding is that we don't know what the outcome would be or exactly how those decisions are made.
This is Michael. Thanks. This is Michael Melgar, one of the two co-leads of the work group. I'm curious if somebody from CMS is on the line who could speak to that.
Hi, this is Mary Beth Hands. I am reaching out to folks as we speak. I want to make sure I don't overspeak on this, and will reach out as soon as I get an answer. So apologies that I can't just jump right in, but we're trying to get something for you all.
Thank you, Ms. Hance. When you get a moment, feel free to raise your hand and I'll call on you. We're going to move to Dr. Brooks next.
Yeah, thank you. So a couple of things. First, at least with Pfizer vaccine, in my mind, I'm kind of putting both vaccines together because our vote is going to be not vaccine specific, I assume. Dr. Lee had said something about just the burden of disease. And one of the slides, it said for 1 million vaccines doses given, 25,000 outpatient visits were averted. So that means, I guess ask Jamie to check the math, but that means for 40, you prevent one outpatient visit with 40 doses. And I think that I like that. And I think what Dr. Lee said is it's, you're preventing that outpatient dose, but what if that person had to miss work, or what if they give it to somebody else, or maybe there's double that because a lot of people don't go to get an outpatient visit, they just stay at home and they're sick. So I like that, and so I'm in favor of, that was for 65 and over, so I'm in favor of bullet number 1, period. Bullet number 2, I am definitely in favor of, because that equity data was compelling. 10 percentage point, not 10%, 10 percentage point differences in the number of African Americans versus others with comorbidity for certain areas. That's, 60 to 64. So it's almost like for African Americans from 60 to 64, just treat them like they're 65. And if they were 65, they'd get the vaccine. So I am in favor of both bullet points.
Thank you, Dr. Brooks. Dr. Daly.
This question I think is addressed to the work group leads. You laid out very clearly the drawbacks of a shared clinical decision-making strategy. There are also drawbacks to a risk-based strategy that we know from prior experience, which is, not to go through all of those, but in summary, risk-based strategies don't achieve as much disease prevention as we would like because coverage isn't as high in those. But in this context, did the work group compare and contrast a shared clinical decision-making over age 65 versus a risk-based strategy over age 65? Thank you.
So what I can say is that the work group did consider, in brief, the implications of a risk-based recommendation as well as those of a shared clinical decision-making recommendation. So we do have some backup slides prepared regarding past experience with risk-based recommendations as well in older adults. In the evidence to recommendations slide deck, if we go to slide 155. So this summarizes the past experience with recommendations for risk-based with pneumococcal vaccines. Using nationwide claims data for years 2013 to 2016, adult patients who were aged above 18 but less than 65 were followed from their first diagnosis for a condition deeming them high risk for invasive pneumococcal disease through the subsequent 365 days and were observed for pneumococcal vaccination in outpatient clinics and pharmacies. And coverage remained low under a risk-based recommendation. So coverage among adults in this age group at increased risk was 23.3% in 2018, as compared with adults who qualified under an age-based recommendation, which was as high as 69%. And the factors contributing to this are multifactorial and include lack of information for accessible to the patients regarding their individual level increased risk, cost, accessibility, and other systemic barriers. And then among high-risk adults, there are disparities in who actually receives vaccination according to income levels and rurality versus living in a metropolitan area. And I think my colleague, Dr. Britton, may have additional comments.
And I'll be, Dr. Cotton, if you want to add on after this, but I think one of the other things that the the work group discussed was that these limitations may also apply to a shared clinical decision-making recommendation. You know, access will continue to be potentially different, but risk-based can potentially also be somewhat limiting. And for RSV, there is not a completely established list of risk factors the way there are for some other conditions. So we know that, you know, Michael was able to present some things that we know are associated, but there are other things that we don't have great data on. And so part of the shared clinical decision-making was trying to give flexibility to providers to you know, give the patient a vaccine if they consider the patient to be high risk. And I think that's something that the work group struggled a lot with, was that we don't have that kind of systematic review of conditions. So we could list probably 3 that we have really great data for, and everything after that becomes a little more challenging.
Can I ask a quick follow-up question? So in the overall strategy, it feels like if you vaccinated age 65, that may not be the time when you're at greatest risk. So what does it mean if protection wanes but risk increases? You know, what's the strategy for somebody who then is higher risk when they're 70 and we're vaccinated at age 65? Thank you.
I think that's a great question, and sort of highlights the uncertainty that we have in the duration of protection. We know from the clinical trials there is statistically significant protection for at least 2 RSV seasons following vaccination, but what happens after that is really unknown, and will require additional studies, either by the manufacturers or observational vaccine effectiveness studies. So for that reason, the voting language that we've put before ACIP is for a single dose. And I think an age-based recommendation, I think I want to acknowledge, has that limitation in that adults who are 65 may be getting a single dose without knowledge of what that means 5 years down the line, you know, when there will be recommended to get another dose in the future. And we're subject to what data that or subject to limitations in what data that we have.
Things I thought about were the high burden of disease, and that we can save lives this year, lives, hospitalizations. You know, we could have a significant impact this year, so that's why we wouldn't want to delay further. The other issue is that there are other vaccines emerging on the horizon, and so this field will undoubtedly change within the next 5 to 10 years. We'll learn a lot more, so we're trying to make a decision as best we can with the data we have now at this time. And we are also emphasizing equity and good vaccine availability for all people. So these are all the things that we thought about in great depth.
Thank you. Ms. Bata?
So as I hear this conversation, I think we should remove the clinical decision-making altogether and just bring our age down to 60, because that 60 to 64, that disadvantage of clinical decision-making is the fact that it creates disparities, and we already have a disparate group in terms of disease burden. And so it's almost a double whammy. I think we need to make sure that we are catching those individuals that haven't been caught in the past. Otherwise, we're excluding them even more so.
Thank you, Ms. Bata. Dr. Lear?
I just want to clarify making motions and sort of the process. My understanding is that we can make a motion, and then the motions can get amended. If they get amended, the amendment gets voted on first, and then if it fails, then the motion gets voted on. Correct. Okay. So when the time comes, I'm ready to make motions.
Thank you, Dr. Lear. I just want to make sure, because we have a series of hands raised. I'm just going to acknowledge that we are going to go over time, even though my committee members tell me I don't give them a break. I'm not going to give you a break. I'm sorry. But we are going to go over, because I think this is a very important conversation for us to have, as I think there's still a lot of issues floating that we need to discuss. So, Dr. Talbot.
My comments in regard to Ms. Bata's comment, I think the work group really struggled with that and agree. I think the problem is we saw those 6 neurologic complications, and it is unclear what the diagnoses and cause of those 6 neurologic complications are. But of note, all 6 occurred in the active comparator and not the placebo. So it's really hard to ignore them, even when it may not have been Guillain-Barré, it might have been CIDP, or it might have been this or that. Because we didn't see them in the placebo. We only saw them in the active comparator. So when we look at an age of 60 and say, we're going to make this equitable, we also might make it lethal to someone who's not at high risk. Someone who may not be hospitalized for RSV may then be hospitalized for Guillain-Barré or whatever neurologic complication it is. So that's really been the struggle of this group, is the real lack of knowledge of how well does this really work? And I have a whole page written of comments that I've told Grace I'd be really good about, but I just wanted to address that really fast.
Thank you. And I wanted to add in a few comments I've been collecting up along the way. So first, I just want to acknowledge Dr. Long and Dr. Sanchez's statement that I understand that this will not result in sterilizing immunity. However, I do think it will shift the burden of infection to be less severe overall, potentially, in addition to potentially protecting those who are at highest risk from severe disease. So in my mind, that is still a benefit that's worth considering. And I will say that I in general, I recognize there's many uncertainties on the table, but I have been overall very impressed by the high level of efficacy we've seen, at least from the trial data to date. But I'll add my caveats to that. The other thing that I think would be really helpful going forward in the future will be to understand the epidemiology of RSV A and B, given that one is bivalent and one is monovalent, recognizing that the efficacy could shift season by season, just like flu. So starting to see the data broken down like that, I think for me as a member would be helpful in future seasons, recognizing that I don't, for the moment, we have the information we have. Also for the manufacturers to present that in the context of their trials would be incredibly helpful, since I recognize that we are focused usually on the US, but many of the trials are happening in other countries. The second point I wanted to make, or sort of the big points I wanted to just highlight, are for this particular vaccine, for me, I would say there are 3 components that are actually influencing my decision-making with regard to the votes that I'll ask the team to put up again, which are safety, cost-effectiveness, and equity. I won't say much more about equity. I think those slides were really well done, and the framing of the issues was excellent. But generally, that is always where my head goes. So I am very much in favor of ensuring that whatever recommendations we do make promote equity as a foundation. With regard to safety, so I am also very appreciative of the FDA ensuring that there's going to be post-marketing requirements and commitments in place, specifically for potential immune-mediated diseases, as well as for atrial fibrillation. I think both of those are really important to ensure we have. I recognize, looking at the long time frame ahead, that the manufacturers have up to 5 years to report. I do think that that's really important information from the committee. While I recognize there's annual reporting, I'll ask if the work group might be able to come back at some interval to share with us any updates, in addition to any updates the CDC has, because that benefit-risk balance is pretty important. And I recognize there's uncertainty around that. The other thing I will say with regard to, sorry, I've been holding my comments for a very long time, so you're going to have to bear with me. The other comment I wanted to make is that I am realizing, as we are now embarking on a journey of really protecting our older adult population, and as we have more vaccine candidates available, one of the interesting aspects of vaccine safety has been that we've started to see more safety events that actually seem to be related to the disease itself. And I think that really hit home for me with COVID. And, it's very similar to the zoster vaccine, where we know zoster itself can cause GBS and at a much higher rate than we had previously realized. But because we have such intense scrutiny around safety, which is incredibly important for to ensure that we are making the best public health decisions possible. I'll just say that I think of vaccine safety differently now, and particularly in older adults, than I did probably 5 or 7 years ago, where my presumption was that it may be related to the vaccine itself. I'm starting to realize that it's an error of omission versus commission in that we are protecting a huge number of people against the diseases that these vaccines were created for. At the same time, we know that many of these diseases not only cause the disease itself, but often have secondary complications such as GBS or arrhythmias. And we see that very rarely in children, I'm going to say, and it may be under-recognized. So just a push for us as we're continuing to look at the epidemiology of RSV in more granular detail and understanding it better, to also look to see if some of the adverse events we're seeing are actually complications of the disease process itself. And putting that into context, I think, would be incredibly helpful for the committee. And I realize all of these data are emerging over time. So I am fine with the fact that we have to make a decision under conditions of uncertainty, and I appreciate that we're going to continue to look at that information going forward. In the interim, I would say a couple things related to safety also is although we didn't talk about it, I mean, I'm noting that co-administration, both from a immunogenicity perspective, non-inferior, but maybe slightly lower in trend, and then also just from a safety perspective. Both of those things give me pause about co-administration for these particular vaccines. And again, emphasizing that in the past, while our general recommendations have always recommended concomitant vaccination because we don't want to miss any opportunities. It's really hard to get adults in for vaccination, so I want to acknowledge that. It really impacts our ability to deliver vaccines because it's really hard to get people in. So it's a trade-off, but I think in this case, I don't personally feel comfortable, and so my clinical guidance, similar to Dr. Cotton's, would be, you know, if you have the opportunity to separate them, that's what I would do. But if for whatever reason they just want to get it all done, you know, I would be supportive of that too. I just want to make sure that we're acknowledging that we don't have sufficient data in my mind, and I'm noting a lot of the immune-mediated diseases are related to, or may be associated with co-administration, or may not. So further investigation into that. And as similar to what we've done with other vaccine adverse events, one request I might have for the vaccine information statements, which I realize would come well after any kind of a vote, would be to consider incorporating that information in there, similar to what we did with febrile seizures for the MMR and varicella vaccines. So we at least informed people that there is a potential risk so that there's awareness. And then the final thing I'll just say is with regard to cost effectiveness, so a couple things. One is I recognize, again, that the revaccination issue will come up, and I very much agree that we have to make the decision in the moment, but it does and will impact the cost effectiveness of these vaccines, if they're good for a season or two versus if they're going to be good for the duration, 10 years, 15 years. And so my biggest concern of the day is going to be that we typically understand what the cost is when we're making a recommendation about a vaccine. And while I am very comfortable with the ACIP voting language as is on the slide, I don't feel like I can make a decision without understanding what the costs will actually be. So looking to the chair of this particular work group, because I don't know how to move forward with a vote until we have complete information. I am fine with moving forward with uncertainty, and we will continue to collect more information as we go around efficacy and safety in the long run. I don't know how we do this without cost information, and that seems to me something that's very imminent and obtainable. And that information is actually critical because it influences my votes on both of those things. I'm done. Thank you.
All right, so I've been very good, and I wrote all this down because I've had a lot of thoughts, and this has kept me up several nights, to be very honest. And I am not as comfortable with the uncertainty, and I will talk about why. And I'm talking about this as a geriatric infectious disease provider. The RSV vaccine studies were large and met the FDA agreed upon endpoints to support licensure. However, the data generated by the vaccine studies are inadequate to determine how these vaccines should be used in both the short and the long term. And these are the reasons. One, there's little to no information on the vaccine efficacy in the populations at greatest risk. These high-risk populations include those over 75 years of age, those residing in nursing homes, those with comorbid conditions, you know, the usual amount of comorbid conditions, not the ones included in the trial, and those with an immunocompromising condition that has been mentioned many times. The licensure studies were done in adults who were younger, and had fewer comorbidities than the rest of the general population of the same age. More importantly, trial participants were much healthier than those typically hospitalized with RSV-associated illness. The population studied was at risk for RSV infections, yes, as we saw, but they were at low risk for hospitalizations, as evidenced by the very small number of hospitalizations seen in both studies over 2 seasons. And this is not an issue of the size of the study, it was the issue of the participants that were enrolled. Randomized control trials are needed to determine vaccine efficacy in these groups at highest risk for RSV-associated morbidity and mortality. Observational studies are suboptimal for establishing efficacy, and if vaccination is recommended for these high-risk groups, clinical trials will no longer be feasible for ethical reasons, and we will have missed the opportunity to obtain the best level of evidence for vaccine implementation. This is critically important in places like nursing homes. We have no idea if it works, but we're going to extrapolate it and use it. It may be better to vaccinate the healthcare workers and the providers that work in the nursing homes. But we won't have that, and we won't know if this vaccine works if we don't do the randomized clinical trial prior to implementation. I already talked about my thought on the serious vaccine safety signal. 3, there is little to no data on re-immunization. RSV immunity wanes after natural infection. The clinical trials have shown protection into the second RSV season. However, efficacy waned over time for both vaccines, but it is unknown if a second dose will restore efficacy and the best timing for a second dose. And that's just the second dose, the third dose, the fourth dose, the fifth dose, and so on. It is also unclear if any studies are planned to determine optimal revaccination timing. The ones that have been proposed seem small and inadequate and only associated with immunogenicity and not efficacy. And we have learned quite well that older adults may produce antibodies but still not have protection. We especially need these studies on revaccination in those that are frail, those with cardiopulmonary disease, and those that are immunocompromised. Number 4, co-administration. In pediatric trials, new vaccines are also tested in co-administration with previously licensed vaccines to look for adverse events and changes in immunogenicity. Older adults should receive the same consideration. We are looking at using RSV as a seasonal vaccine, and there are currently 2 seasonal vaccines that are recommended for adults 65 years of age and older. And those include influenza and COVID-19. We saw a little bit of data on influenza, showing a slightly lower amount of immunogenicity with unclear clinical implications. And we have no trials, and no one has mentioned giving this vaccine with COVID. So all 3 need to be given, and all these studies need to be done to look at immunogenicity, to make sure that we don't actually reduce protection against COVID and influenza, which we know cause significant and severe disease in this population. Also to make sure that we do not cause unanticipated or worsening rates of severe adverse events. I truly believe that rapid introduction of this vaccine would prevent some hospitalizations this year. I've been studying RSV for years and know it's a disease that needs a vaccine for. However, waiting for the information that was outlined above, or what I just said, I actually just added the above and I didn't write that. I don't know why I did that. If we can get the information that we're all struggling with because we're lacking, we may actually increase confidence in these vaccines. We may encourage other healthcare providers to use them. And we may actually prevent more RSV-associated hospitalizations and death in the future because we actually know how to use the vaccine. Thank you.
Thank you. Dr. Long.
So I'm interested in preventing as many hospitalizations and potential deaths this year as everyone else is. And I think we should do that, but I would only do that with purposeful restricted use of the vaccine until we work out, was the risk high enough for you to get it to take on the possibility of having a neuroinflammatory adverse event. And so that I could only vote for this in favor of this vaccine if we had some restrictions on its use in all age groups. Understanding that that is not what we eventually want to do, but we also eventually need to know if it is boostable. If it's not boostable, that's a whole different story, and we don't want to waste that 2 years of protection in the age group that's not going to benefit the most and might get Guillain-Barré or some neuroinflammatory syndrome. And I think the public would thank us for that kind of conservative approach, rather than saying, we'll just see who gets some neuroinflammatory syndrome, and then we'll know if it's in excess or not. I don't know if there's a neuroinflammatory syndrome that's associated with this vaccine, but that's just the point. So I could only be in favor of restricted use in all age groups.
Thank you. I'm going to call on our liaisons in the room, and then I'm going to pose a question to our colleagues. So Dr. Juthani, and actually I'll just ask our liaisons, I apologize, but if you can keep your questions or comments brief, we'd appreciate it.
Yes, thank you so much. Just briefly, I wanted to comment on bullet 2 and on risk assessment. So shared clinical decision making, makes a lot of sense, but I just wanted to comment that I think really simplifying the risk assessment with the range of potential vaccinators and people who would be making that risk assessment in that age group would be really important. And so I understand we don't have as clear risk factors identified, but even if we utilize the 3 big buckets to say that these are people who would be at highest risk, the cardiovascular, lung, and diabetes, something along those lines. I just want to really advocate for simplifying that risk assessment. And I think risk assessment is necessary, although I agree with what you're saying about shared clinical decision-making, to make it easy for the providers. Thank you.
Thank you for that comment. Dr. Howell.
Hi, Molly Howell, representing the Association of Immunization Managers. To further inform the equity discussion, I just wanted to inform the committee that because there is not a Vaccines for Adults program in the United States, similar to the Vaccines for Children program, most immunization programs across the United States will be unable to provide RSV vaccines for uninsured adults due to very limited budgets and being currently unable to supply some of the ACIP recommended vaccines for uninsured adults. And there may be a few programs who are able to if they receive state or local funding, which will create differences across areas in the United States. And so I just wanted to make sure the committee was aware of that. And secondly, I'm also hearing concerns from skilled nursing facilities and pharmacies about Medicare Part D coverage and how vaccines are administered and reimbursed in skilled nursing facilities. And so I just wanted to put that out there as well. Thank you.
Thank you for providing that feedback. Dr. Good?
Yes, thank you. Kelly Good, American Pharmacists Association. I just wanted to comment on the issue of the delivery of the vaccines. So there seemed to be some concern about if it were a Medicare Part D vaccine, but I want to assure the committee that pharmacists are prepared in an ideal position to be able to provide vaccine recommendations, patient education, and work with patients on shared clinical decision-making. Patients with chronic illness are most likely on medications and are in pharmacies more often, estimated about 35 times per year, providing many opportunities for these crucial conversations and decreasing missed opportunities for vaccination. Thank you.
Thank you for providing that input. Dr. Goldman.
Thank you, Dr. Lee. Jason Goldman, American College of Physicians. Just to be brief, and to echo Dr. Lair, I too am able to give Part D vaccines. Unfortunately, you have to go through a system where you essentially bill as a pharmacy, which can be a barrier to care for many physician offices. I'm also concerned about shared clinical decision-making because in the past, these recommendations have actually made it more difficult to administer vaccines, especially when you consider that many insurance companies will take up to a year to implement the ACIP recommendations for reimbursement. In addition, if it's not a clear-cut recommendation, they may balk at reimbursement, making it even harder. And the third part is that this may actually hurt equity for those who do not have insurance coverage, as previously been stated. There is no Vaccine for Adults program. So many in the 60 to 64 range who rely on employer-based coverage may not be able to get their vaccines because they don't have insurance coverage. And finally, really the risk assessment piece of it is a discussion between the physician and the patient, and it can be very difficult to add that burden without clear-cut guidelines. So I think shared clinical decision-making may actually hurt reimbursement, hurt access to care, and actually decrease equity. So I would hope that the committee can give a very clear-cut age-based safety recommendation so that we can implement the vaccines appropriately. Thank you.
Thank you. Ms. Arthur?
Thank you, Dr. Lee. So Phyllis Arthur on behalf of BIO. 2 quick points. I think there was some discussion about how it's determined which vaccines go into which part of Medicare. So statutorily, only hepatitis B, flu, and pneumococcal vaccine are included in Part B, and COVID vaccines included in Part B because of the law. So all other vaccines for Medicare recipients in Part D. But we did have recently legislation passed at the end of last year that actually makes it so there's zero out-of-pocket cost for patients in Part D. So in terms of access to patients with regard to no cost sharing, that is actually a good thing. Secondly, I just wanted to make a point about the fact that there's generally not been a precedent for companies, manufacturers sharing their finalized pricing before the recommendation process is complete. So I know the cost-effective analysis is an extremely important part of the ACIP process, but generally in the past has been done without necessarily a final knowledge of the last cost that will be given in the marketplace. It's also important to note that many patients in both the public and private sector are going to have access to pricing that's discounted through various programs as well. So I wanted to just make sure there were a couple of thoughts with regard to the pricing issue and remind people that in general, manufacturers try to price to the best possible public health impact. Thank you.
Thank you for those comments. I'm going to take a pause and ask. I'm going to put Dr. Wharton on the spot here. While we typically, and Ms. Arthur, thank you for those comments, because I appreciate it, because I'm a little bit hung up on this, which is in the past, I feel like it's either been clearly on one side or the other. I think in terms of the cost effectiveness, it weighs more heavily for me because of the estimates that are being given, as well as the uncertainty about the price. But generally, when it's in one direction or the other, then I will focus on other domains of decision-making and the evidence to recommendation framework. In this case, at least for me personally, it becomes an important issue for the decision and the vote. And in my recollection, while we often are doing these in advance of the approval process, my assumption was that once a vaccine is approved and licensed for use, it usually goes to market, and then we have clarity about whether those assumptions are correct. I'm going to ask Dr. Wharton if she can comment on that, and if in this situation, knowing that, at least for me, that this would influence my vote on this particular set of votes here for the adult RSV vaccines, if there's any other opportunity we have to think through the process here.
Thank you, Dr. Lee. We are here for 3 days, and if we had an opportunity to get more clarity from the companies on price before Friday, we could vote with that information in hand. And I have to say I do have some discomfort with the committee's obligation to consider cost effectiveness absent at least a narrow range of projected prices. Both of these vaccines were licensed last month. It's not like they were licensed earlier this week. And from my perspective, it would be very helpful to have more information than we have about pricing before we ask you to vote.
Dr. Lair. Oh, wait, I'm going to go back to Dr. Romero. Sorry, he holds rank.
Yeah, thank you very much. So it is within the purview of the committee to delay the vote if the data is important to you, and we can attempt to do that. Sorry, my voice is a little rough still. But I also want to remind the committee that this is not the first time the committee has voted without all the data they've had. And I still remember one particular vote where the director came to address us specifically because of that. that there was a lot of consternation a lot of concern among the voting members. And it's, in essence, boiling down his statement, it was, we vote on what we have data for, we monitor these vaccines, and we can modify our data our vote in the future. I want to remind everyone that we have one of the best vaccine safety systems in the world. We have the ability to rapidly acquire information, rapidly assess it, and act on it. We saw that during the COVID pandemic. That system is viable and is in place. So we can follow. There was a comment about surveillance. We now, NCIRD, has a 5th division, the Corvid division, that will be tasked primarily with following epidemiology of these respiratory diseases. And we have now dashboards that are available to the public for this. And we will go forward tracking these and looking at not just the incidence, but also the subtypes that are available circulating in our communities. So I think we're well poised, to monitor this vaccine going forward. I simply remind you that we have the data that we have, and to delay this a vote or to delay your decision based on more data to come may delay and may deprive individuals of the benefit of this vaccine for years to come. And lastly, I remind you about the issue of equity that has always been very important to us. I think that the data has been presented very well by both leads about how important equity is in deciding who can get this vaccine. And closing the door to this vaccine to one particular age group may disenfranchise our populations. I'll end there.
Thank you, Dr. Romero. Dr. Lair?
So from my own summary, I'm hearing several options for the first bullet. One option is to delay the vote until Friday. One is the option to delay the vote until the future. One option is to vote as it is, and one option is to vote with shared clinical decision-making. I was about to make a motion for as it is. I'm curious if people can give me a sense of whether they want to delay, because if that's want to delay, I'm perfectly willing to make a motion to delay.
Well, actually, why don't we put the motion on the table, and then I think the timing of the vote we can discuss, but why don't we get the motion on the table, because I think that would actually be helpful for furthering the conversation.
Okay, so then I would like to make a motion for the first bullet point that adults 65 years of age and older are recommended to receive a single dose of RSV vaccine. That's my first motion.
Hold up. Can I get a second on that motion?
Brooks, second the motion.
Thank you. So it's been motioned and seconded that we accept the language on the slide. The adults 65 years of age and older are recommended to receive a single dose of RSV vaccine.
My second motion is the second bullet point without the last few words. So to read it out correctly, individual adults aged 60 to 64 years may receive a single dose of RSV vaccine using shared clinical decision-making.
Thank you. Can I have a second? I see Dr. Paling.
I'll second that motion.
Thank you. So it's been moved and seconded that the amended wording will be individual adults aged 60 to 64 years may receive a single dose of RSV vaccine using shared clinical decision-making. Thank you. We will, are there any additional comments people would like to make before we move on? I see, okay, 3 hands raised, and then we're going to move on to the next section. So, because we are running very far behind today. Dr. Talbot, Dr. Sanchez, and then Dr. Cotton, and we will close this session.
I would like to respectfully disagree with Dr. Romero, who I hold in high esteem. So this is, I am one of your researchers that does flu, COVID, VE studies in many different facets. And our observational studies are awesome, but they are not perfect. And they do not provide us with the information that we need. And I feel like if we don't start asking for this information up front as we introduce new adult vaccines, we're never going to get the data. And so I'm trying to balance not digging in my heels and trying to encourage our colleagues who create these vaccines and do the studies, to start doing the studies for the population that the vaccine is intended for. We are still thinking it's the 1940s and testing flu vaccine in Army recruits, and 1960 introducing it into older people without any trials. And so I'm pushing very hard so that we, in the future, and with this vaccine, get the data up front. Because I think if we continue to settle, we will only get, we'll always be in this position. Thanks.
Dr. Sanchez?
With respect to the first vote, would we vote on this and then see? Because I think another option has already been mentioned also was adults 65 years of age or older based on risk assessment.
So you can make an amendment, and then we would vote on your amendment first. So, and that's a very reasonable thing, and I chose not to do that, but I think that's a very reasonable way to go. I can't do it because I made the original motion.
Well, okay.
So let me intervene, because clearly my committee members need maybe another 5-minute break after this. But
so can I make that amendment?
would you like to make a motion for an
60.
amendment to vote number 1?
Yes. So I'd like to make an amendment to adults 65 years of age and older are recommended to receive a single dose of RSV vaccine based on risk assessment or based on clinical decision-making.
Second.
Well, okay, let's clarify, because that's very, those are different things. I just want to confirm. Are we talking about shared clinical decision-making or something different?
Risk assessment.
So you're making a risk-based recommendation for vote 1 and then a shared clinical decision-making for vote 2?
No.
Yeah, no.
It is shared clinical decision-making for vote 2 now. I just want to clarify, because those are 2 different votes.
We're talking about adults 65 years of age and older.
Correct, but shared clinical decision-making as a construct and a process is different than a risk-based recommendation.
No. So risk-based assessment.
You would like to make a risk-based recommendation for adults 65 years and older,
Yes.
with risk groups TBD.
Are you sure of that? Because I think a lot of people are thinking shared clinical decision-making.
Risk groups remain poorly defined.
You can do what you want, but I think a lot of people are pushing for shared clinical decision-making.
Yeah, and sort of before it goes to a second, I just want to make the distinction that it would then put 2 votes of very close age groups right next to each other that would not be concordant, which I think from an implementation standpoint would be incredibly challenging.
Yeah, so, yes. So adults 60 and over would be recommended to receive single dose of RSV vaccine based on shared decision-making.
Using shared clinical decision-making.
Yes,
So
yes.
you would amend vote number 1 to be adults 65 years and older are may receive a single dose of RSV vaccine using shared clinical decision-making.
Yes.
For vote number 1. Okay, do I have a second for shared clinical decision-making for vote number 1 for 65 and older? Okay, Dr. Long, you need to speak up, please, into the microphone.
I second the motion.
Okay, Dr. Long, it's been a second to that. So it's been moved and seconded that there be an amendment to vote number 1 that adults 65 and older are recommended, may receive a single dose of RSV vaccine using shared clinical decision-making, period. And I would like to hopefully stop there. Are there any additional comments or questions? Oh, wait, sorry, with the amendments. Dr. Cotton. Okay, we're done with that amendment for now. It's on the table.
Can you remind us of Robert's rules about that? So we would first vote on the amended?
Correct. You have to vote on the amendment.
If the amended failed, would you entertain other?
The original vote, the original motion on the table. It goes back to the original motion if the amendment fails. Dr. Cotton.
Thank you. As the work group chair, I would just like to remind the ACIP members that the work group for people 65 years of age and over thought that there was actually moderate data for desirable anticipated effects. that the undesirable anticipated effects were low, and that the majority opinion was that we favored intervention. Okay, so this is people who have spent many months, virtually every week in recent times. You can see the amount of data and research that has gone into this. So although we are having this amazing, interesting, vigorous conversation now, I would just, these are slides sort of 46, 47, 48, 49, just contemplate what the work group has spent time doing rather than perhaps changing opinions now. I will also just second the issues that I have major concerns about cost, and I do think that the companies who make these vaccines are beholden to share cost with us, because I personally found it upsetting that GSK virtually doubled the cost of vaccine in recent times, and I wonder what the future holds. Thank you.
Thank you. Dr. Brooks?
Yeah, it's a point of order, Madam Chair. When a motion is made and seconded, the next step is discussion. So I think that we were talking about discussing this at the end of the day when we actually go to vote, or are we discussing it now?
We will have a period of discussion, but I would say that I have a question to Dr. Wharton about the timing of the vote. So for today, may I ask the committee if we can please move on to the next session? Right. Because I think we will have the opportunity to discuss further prior to any vote that's had. So how about that? I'm going to give us literally 1 minute. I'm, again, just to change over sessions, but I wanted to give my committee members 1 minute just to change over, and then also for the speakers to change out. So please hang on for a minute. Thank you, everyone.